Apologies from Loretta Gloucester, our head governor as well, who might be joining us later.
Okay, thank you. Declaration of conflict of interest. No declaration of conflict of interest, just checking. Okay, colleague. We'll move on to item 47, minutes of the Board of the Directors meeting held on the 25th of May. Can somebody move to approve, please?
Got one comment on this one. Page 16.5, it sort of says that, well, I don't, about what I said, but it doesn't really make sense. Paragraph 5, I think it is. It should actually say that I said that one of the tables showed an increase in the number of incidents reported. These were not an increase in moderate severe incidents and suggested the pressure of a healthy reporting culture. That's what it should say, but it doesn't actually make sense what's there.
We'll correct that.
On that,
Thank you.
yeah, and also there's also in the same area a slight conflicting statements from Leanne and Aaron about the indicative review date. Leanne says it will be sorted, and Aaron says it will be discussed at 6-month review, but actually it's now on the we call it, you know, the IPR. That's the ICD and the IRD and the IPR. So I think, as it says, two different things there. It would just be appropriate to.
So I don't think there's a conflict. I think the comment I was making, that was a number of other issues we were talking around the IPR,
Right.
and that a 6-month review would be a discipline to reiterate the report. So
Right.
what we were getting into a conversation with the other issues about other performance elements,
Right.
and my advice to the board was to not add and chop and change too quick and wait for the 6 months.
I remember that's what you
Yeah.
said.
Just need to minute.
All ones just to make sure that's been like that. Yeah.
We'll catch that up. Thank you.
Okay, thank you. I'll take into account those corrections. We're willing to accept the minutes. Yeah, thank you. Colleagues, before I go on to the action sheet, I just want to introduce our new incoming non-executive director, Karen, who's sitting here. I don't know if you can see it on my right as I wave with my right hand. It might be on the left as you look at the screen. Karen, you just want to say a few words to introduce yourself?
Yeah, absolutely. Thank you, Mike, and good morning. And it's great to see everybody, and particularly fabulous to be in the room. So yeah, I'm delighted to be joining the board as a non-executive. I've just had a very long history of working within health and social care, and a very long history in terms of association with the trust. So I'm delighted to be taking up this role, and really look forward to working with you and getting to know you much better over the coming months. So thank you.
Very welcome.
Welcome, Karen.
Welcome.
Okay, I won't ask everybody to introduce themselves. We will do that as part of your introduction, if that's okay. You're very welcome. Okay, action sheets and matters arising. Paul, anything in the action sheet?
Thanks, Mike. A review of the action tracker has been undertaken. You can see where a number of items have been scheduled for either forthcoming meetings or meetings for today. Just a couple of items to call out for today's meeting. You've got the urgent care improvement plan, and then later today there'll be a preparatory session regarding the meeting with the national teams for the recovery support programme. But other than that, Mike, nothing to note.
Thank you. Just checking with colleagues, nothing under, okay. Then we'll move on to matters for consideration, item 49, patient and staff story. This is a presentation from the Armed Forces Network, and we've got both Gillian Day and Barry Rigg here. For those of you who don't know, Gillian Day is chair of the Forces Network, and Barry is head of our patient experience. They'll both be attending via Teams. Are you here?
See Gillian.
Gillian?
Yes.
Oh,
Yes,
yeah.
hello.
Good
morning.
Brilliant. So welcome. You're going to tell us or give us a presentation which will include a voice recording from Army colleagues who worked here. I'm going to pass the floor over to you, Gillian, and then please leave some time for questions at the end of the presentation. So over to you.
Thank you, Mike. Hello, my name is Gillian Day, and I'm project lead for strategic recruitment and retention, and also the Armed Forces Network lead currently. And as Mike said, with me today is Barry Rigg, Head of Patient Experience. The Armed Forces community includes those currently serving, reservists, veterans and their families, spouses, partners and children. And pictured here is Ros McMeeking, who's a member of the network, who's also a reservist, clinical governance business partner here at UHMB. In the UK, a veteran is anyone who has served for at least one day in Her Majesty's Armed Forces. That's regular and reserve, and there are approximately 2.4 million veterans in the UK, making up between 3 and 9% of the population. Our patient experience team and ICC colleagues are working with the veteran community here in Morecambe Bay. Here you can see significant steps and events since 2016. Which the Forces Network and colleagues have been instrumental in. 2016, we gained the Employer Recognition Scheme bronze level to where we are today, having submitted our application for Employer Recognition Scheme gold, which is real testament to the work and dedication of colleagues across UHMB to get us to this point. And it sends a clear and reassuring message to the Armed Forces community that UHMB is a great place to be cared for and a great place to work, a place where we're welcomed and supported. And there's some really significant achievements over the years there, from Stepping to Health, and we were one of the first 30 organisations in the NHS to gain that accolade, and most recently becoming a veteran aware hospital in September last year, which is significant and very good for the organisation. You may be aware that since March this year, we've had combat medical technicians, CMTs, working within our emergency department and same-day emergency care at RLI. This provides great additional support to our clinical teams whilst offering the CMTs valuable experience in order to complete their clinical portfolio. I'm now going to invite you to listen to Private Hancock from 3 Medical Regiment, who is currently working in our emergency department at Royal Lancaster Infirmary.
Private Hancock, 3 Medical Regiment, Royal Lancaster Infirmary.
Hi, Private Hancock, thank you. So could you just tell me a little bit about what you're doing here and what you're hoping to get from your placement?
Here on the placement so far, I've been floating around helping in a lot of different parts of the A&E department. I'm in resus at the minute, and I was in 3 different wards on my first shift. And I'm hoping to get a lot of clinical exposure out of this because I feel it right with my career. So
that's great. And how have you found it interacting with the staff and patients?
Interacting with the staff is really good. They want to know what I do within the military, and they're always keen to show me what they do and the processes they go through and how it differentiates from what I do.
And working with the patients?
With the patients, it's a lot different to what we do because we're mainly dealing with like younger or middle-aged healthy men, where here there's or men and women, and here it's there's a lot of old people, and there's a peds ward here or pediatrics ward, so I could get the possibility to work there, and that's a very wide age range, so I feel like that's going to be a difficulty, but I feel like the staff here will definitely aid me in doing that.
And that's great. Is there anything else that you would like to add about the opportunities that this will bring and how this helps you as a soldier develop?
The opportunities, I feel like there's a lot of things that you'll see here and have to deal with here that you weren't necessarily out in the field, but then again, coming to a placement, I feel like if you see it like beforehand, then you're not struggling with what to do and what processes to take when you eventually do see it out on operations or on an exercise and so forth. So that's how I feel like it will help a lot.
Brilliant. Thank you so much, Private Hancock.
Wonderful. Thank you.
Just before we move on, pictured on the slide that you see there on the right hand side is UHMB colleague Andy Lamb, who is Capital Projects lead, also a veteran, and he's Lancashire Army Cadet Instructor and Morecambe Detachment Commander. On the left is Sergeant Damon Williams. He's from 208 Army Reserve Centre, who comes on site each year to talk to colleagues and visitors about becoming a reservist and the benefits to all involved. When we're thinking about the health of veterans, overall it's similar to that of the general population. However, there are some significant differences. The most prevalent health conditions are musculoskeletal, cardiovascular, respiratory, hearing loss, mental health, and alcohol misuse. And these are things that we need to be aware of as veterans access healthcare. And it's important that we help provide information and links to other organisations for our teams so they're able to provide the best possible care for veterans accessing our services. I'm now going to hand you over to my colleague, Barry.
Hello, good morning. My name is Barry Rigg, Head of Patient Experience here at Morecambe Bay. We will now hear from Neil. Neil's been one of our patients in one of our hospitals. Neil has provided a written account, however, we've also got a verbal recording, which we'll now share with you.
Hello, my name is Neil. I am a veteran who served in the Royal Air Force. I was admitted to hospital for emergency care following a motor accident. The accident resulted in a leg injury that required extensive physiotherapy. When it became clear that I needed extensive rehabilitation, hospital staff referred me to the Defence Medical Welfare Service charity for additional support. SAR, the Defence Medical Welfare Officer, stepped in to help me and my wife move forward and put in place the necessary steps in preparation for my discharge from the hospital later that month. It was expected I had some short-term mobility issues, and my home required some modifications prior to discharge from the hospital. By liaising with the physio team, Sarah was able to understand the requirements and initiate the process of adjusting my home. I felt a sense of anxiety around my lifestyle change, and it was identified that further mental health support would be required. In the run-up to my discharge, Sarah ensured that I felt confident in my ongoing physio plan and that I had all the tools and contacts in place to ensure a safe, short healing period. My anxiety around the whole process was greatly reduced due to the help and guidance of Sarah and Defence Medical Welfare Service. Sarah was even able to help me apply for a personal independence payment, which I did not know I was entitled to. My ask is that the relevant hospital staff know more about the Veteran Awareness Scheme and that veterans feel able and confident to come forward and declare their status to their GP and other healthcare providers. Thank you for listening to my experience.
So that was a short story from one of our patients, our patient Neil. Since speaking with Neil and since working with a number of veterans, we've implemented a range of supportive mechanisms here in the Trust. So we're now actively capturing veteran status on the electronic patient record. We've been working with our discharge teams and our ED colleagues particularly to identify veterans and to offer additional support where required. And we've also adopted from the Stockport NHS Trust their veteran passport. We're working with our ICC colleagues in the communities to ensure that ICC colleagues are working with veterans as citizens before becoming a patient if required in one of our hospitals. And finally, something we're really proud of is we've now started to include veterans as one of our protected characteristics, which we consider when undertaking our equality impact assessments. I'll now hand you back to Gillian.
Thank you, Barry. It has to be said that I am extremely proud of the Forces Network. I think it was good that we were able to set it up and be instrumental in getting where we are now. Barry's mentioned some of the things that we have in place. The network really helps to ensure that we remain compliant with the Armed Forces Covenant. It's all very well getting these accolades, but we need to make sure that we maintain the pledges that we agreed to make to the Armed Forces community. So we do, lots of work in that respect, but that means working collaboratively. So it's not just the network; it's with colleagues across the organisation, clinical, non-clinical, and importantly with external organisations as well. We're all there to support each other and make sure that we can provide the best possible care. It has to be said as well, the network is also a social network and provides that safe place for people to come together when needed. Some of our network members and people who are in the organisation need support from time to time for various things, and it really is important to have that space to come together and be able to speak freely and with people who have perhaps been in the same situation and understand. So yes, the Forces Network has done some absolutely fantastic work, and I know it will continue to do so in the future. Thank you.
Thanks, Gillian. I'll just say to colleagues, that I'm a member of the Forces Network, so I'm just declaring an interest in that. And Gillian, yourself and colleagues have been absolutely fantastic in making sure that it's built up from, as you say, about 5 years ago to now submitting for the gold standard, which is the highest standard of veteran support. And the Forces Network is quite wide. There's a large number of staff that are members on it. We meet at, if I got this right, Gillian, Morecambe Football Club every month for the drop-in with people, and I'm sure members of the board, if they were wanted to come in, they'd be welcome there by the Forces Network. And there's frequent social outings. I think about a month ago there was a sleepover in one of the Lake District areas that people could sleep over for charity. So it's really quite an active area in terms of social support. But in terms of supporting veteran staff and patients who are veterans, it's really played a really important part in getting us towards that gold submission. I'm going to take some questions and then I'll just end with a short piece, Gillian, if that's all right. So I'll look, first of all, I've got David and Jeff and Aaron. David?
Yeah, well, thank you. I mean, thank you for the presentation and for Gillian and for Barry to make this agenda relevant, not just to the workforce, but also to the armed forces and the armed force veterans that in our community and our citizens. I think done fantastic work. And I would just want to highlight, I know the final slide made mention of it, but just particular thanks to Gillian because she's retiring at the end of August, and she's been on this journey with us right from the very start of setting up the Forces Network, making contact and making the socials, even things such as ensuring that we have trust representation at Remembrance Day. Before Gillian, we never did even none of those really simple things. So Gillian, you made a massive contribution, and I hope that the final contribution is recognised through the gold accreditation. But well done, and you'll be severely missed. Thank you.
Thanks, David. You took away some of the words I was going to say, so thank you for that. Jeff?
Thank you, Chair, and well done, Gillian. Good job done so far. I've had personal experience of the consequences of not getting veterans' health right as a GP, and I've seen dire consequences in this area over the last few years, and not just for the veteran, but for other people in the community. So it's a really important thing to do. I think this work could be extended beyond the shores of the hospital through the auspices of Bay Health and Care Partners. There's a thing for practices called veteran-friendly practices, and I think it's accredited by the Royal College. And Hugh might know more about that than me, but because there's only 3 or 4 practices in the whole of Morecambe Bay that I know of that are accredited, and I know there's one in the Grange area. I'm not sure which one it is, but I just think this is something that should be spread out because the obvious thing that's the first point of contact. And I've tried once before very unsuccessfully with my GP colleagues to engage them in this, probably because they've got a million one other things to do, of course. But I just wondered whether you've got 5 minutes to link up with me at some point and tell me how to do it. But well done, and a really good story.
Absolutely, I think we do need to extend those links. So yeah, absolutely, I'll happy to link up.
Brilliant. Thank you, Chair.
Thank you, Aaron.
Thanks, Chair. So I won't pinch any of the Chair's thunder, who will want to say a few words on behalf of the board as well, Gillian, at the end. But you will be sorely missed. You're an exemplary colleague, not just in the armed forces field of the network that you help lead, Gillian, but across the whole of the equality, diversity and inclusion agenda. I know you're a real sponsor for all networks and all colleagues, and I know a number of colleagues will really miss your input and your support. So you're going to leave with our love and best wishes, but I won't steal Mike's thunder at the end. The question I've got is, it was good to hear, Barry. I think you mentioned that in having a look at what options we had available to improve and respond to the feedback, we'd gone out to Stockport and nicked their passports. Great, pinching with pride's one of my kind of leadership traits. And that we'd gone out to ICCs. Jeff's picked up the issue around linking in with primary care. I'm just wondering, we've got 4 other provider trusts in the provider collaborative across the ICS, and whether the other organisations in our patch are doing something similar, or whether this is something we could share across the other providers.
So this is some of our journey of where we've got to today is because we've worked with other trusts. There's still work to do with our other 4 trusts in our provider area. So the answer is yes and yes, and we'll put that challenge back to the new chair of the Forces Network. I've got a dedicated member of the patient experience team allocated to this work, so we can work at pace once we know what we need to do. Thank you.
Thanks, Barry.
Thanks, Barry. Thanks. You mustn't underestimate the work that you're doing there in patient experience in this area. I just want to say a few words to you, Julian, because I know Phil's hungry. Oh, sorry, Phil, I didn't see you there. Do you want to come in?
Thanks. Yeah, it was just on Jeff's point. I think it's a really good point about BHCP. The other things to remember, I think, around that is the reason why local authority is so important. There's 4,000 veterans face homelessness in this country every year after providing their services to us. It won't get too political, but it's real shameful, but the power around homelessness as well lies in us all around BHCP. So there's something we can do there.
Thank you. Thanks. Yeah, I'm sure people will take that on board, Phil. Okay, colleagues, I just want to say a few minutes really just to talk about yourself, Gillian, because you're retiring in the next 6 weeks. And I just wanted to give our thanks and appreciation really from the board to you. Colleagues may not be aware, it's a great one in a pub quiz this, but since the end of the Second World War, Britain has only had 1 year when it hasn't been involved in armed conflict. It was 1968. So every year since 1945, there has always been an armed conflict, and our armed forces colleagues have been out in some degree of operations and theatre. The worst year, not taking into account the Second World War, was the years 2010 to 2012, when we were getting about 100 veterans badly injured every month for a period of about 15 months. 2,500 in total came through. The medical technology and the care that are given today means that many veterans are alive today which just wouldn't have survived those injuries years ago. And they're life-changing, as any of you look at the media. And the biggest problem that we've got is when people leave the armed forces, we used to use the word transition, is trying to get them to understand what the opportunities were back in civilian life, but also getting civilian employers to understand what skills veterans had. People used to stereotype military people as stuck in a routine and not very flexible, when all the research shows actually they're hugely flexible. They can work whatever hours, they're quite changeable, they can move house, move areas. The hardest group to find work for are people in the rifles who are what we would call snipers. But if you take their CVs as transition, they bring brilliant skills around planning, logistics, preparation. You know, so Gillian and the Forces Network and her team has worked hugely in that area to say, look, this is what a veteran's CV translates into a civilian CV, which has been really, really important. The other is the work around supporting veterans and their families, because except for odd places in England, mainly people go back to where they were brought up. Cumbria and Lancashire are major recruitment areas for the armed forces, and they tend to scatter when they leave and go back to where they live. What they're worried about is where are the best schools, where's the best houses, and they don't necessarily want to buy a house when they first come out. They want to rent and then get to know and then get back in their community. And again, you know, Gillian has played a huge part in the Trust's work in that area of reassuring families and children at schools, etc., and helping the NHS to recruit vets. We've got quite a large number of vets community in our Trust, and that doesn't happen by accident. You know, they go where they're appreciated and people understand their CVs and their families get good schools, etc. And then Gillian's played a part and her team in changing policies and practices. So even getting veterans as a characteristic has been so important, because it doesn't guarantee a job. It gets them to come in for interviews and they get that experience of, well, these are the sort of questions you're going to be asked, which is really helpful for people's confidence. And finally, Gillian, you've been instrumental in maintaining good practices. The Trust has a reputation. It has, because we went from bronze to silver and now we've submitted for gold. Hopefully that, again, that doesn't happen by accident. It takes energy, people, organisation, dedication and commitment. And I just want board members to be aware, Gillian, that yourself and many colleagues around you just get on with that. We're not often in the spotlight, but it has a major, major impact on people's lives. So thank you on behalf of the veterans community. Thank you. And on behalf of the Trust board, thank you very much.
Well said.
Thank you. Thanks, everyone.
Ray, want to say a few words or just end with a thank you?
I'd just like to say, as I said before, I'm extremely proud of what we've done and where we've got to, and that is not, you know, it's testament to the hard work of so many people internally and externally. And I just hope that this carries on, and we're sort of the next stage now. If we get gold, then, you know, it's maintaining and onto sort of bigger and better things, and just making sure that we uphold everything that we've already committed to, and thank you all for your kind words. I shall miss it.
I think it's on the Trust website, the details for your any leaving parties that you may be having, Gillian. So you might see a few faces there. All right. Thank you. Barry, thank you very much.
Thanks both.
See you all soon. Take care. Okay, colleagues, we'll move on. Cracking member of staff. I wish you every success, really. Item 50, Chair's Report. It's there in front of you. I don't really go through it every month, but I'm happy to answer any questions. Some of the issues I've raised are in the agenda today anyway. No, thank you. You're happy to note the Chair's Report? Okay, then we'll move on then to the Chief Exec's report. I'll put the floor over to you, Aaron.
Thanks, Chair. So kind of 10 minutes from me on a couple of bits from national, regional and local updates that have been happening over the last month that I've been involved in. But before I do that, I have to recognise that it's Leanne Cooper's last trust board as acting Chief Operating Officer. A massive thank you from me personally, Leanne, and from the exec team and the board. You haven't missed a beat. So stepping up, I think, at a time when we were closing the year, setting up annual plans, leading recovery support programme work, dealing with Opal 4 escalations, making sure that we're submitting relevant bids for things like capital investment, supporting the new hospitals programme. I could go on. That's quite an acting up period for any colleague to come in, and the fact that you've absolutely nailed it and not missed a beat is an exemplary example of leadership from my perspective. So thank you very much from me and the exec team and the board. I know you're not leaving, so we don't need to give a speech, but yeah, a fantastic career ahead of you. So I'm very pleased that you've had the opportunity to operate at board level, and you've done incredibly well. Thank you. So the other updates that I was going to give from a national perspective, there are 2 or 3 areas that the national teams are asking the NHS to focus on. Not unusually, the 3 pillars of our annual plan and our key areas of focus feature around elective recovery, urgent care improvements and financial sustainability. And the board will see items on the agenda today that demonstrate the progress we're making, but all the risks and the pressures that we face on those agendas. So the board will be fully sighted in those areas. But as the system starts to change with the introduction of the integrated care systems and others, I think our performance framework will also shift. And as that gets a bit clearer, we'll be able to bring further updates to the board on those 3 key areas of focus. The second area then is the integrated care systems. They come into operation statutorily from Friday, 1st of July. I've updated a board before around the appointments of the chief execs and chairs and designates, the new executive teams. So there will be a initial board meeting on Friday where the ICS will constitute itself, sign up terms of reference, ratify appointments. Its first public board is on the 27th of July. Early interactions with the regional teams and the ICS teams, again, are focused on those key 3 areas of priority, but also on the reform agenda at systems level. So the interrelationships of things like the provider collaborative board that we belong to, the importance of place-based leadership and places like Bay Health and Care Partners, and also work around health and care integration as a real focus, bringing local authorities, primary care, community teams, BCSFE sectors together. And obviously the board's been input into those agenda items over a period of years, actually, not just months. One item just to highlight, though, and it's signalled in the paper, is the boundary review, the ambition to look at coterminosity of local authorities and health leadership structures to try and get that closer alignment of integration. There will be a report going to that first board on the 27th of July, and then whatever the recommendations are, we'll consider both as a board and Bay Health and Care Partners what that means in practice. And I've signalled a workshop for board at the end of summer so we can start to look at that in a little more detail. Locally, a lot of the work is around in the region, supporting the teams at place level, Bay Health and Care Partners and the ICS in setting up the new structures. I do want to say, though, and recognise, especially with Jeff round the board table, tomorrow will be the last day in operation of the Morecambe Bay Clinical Commissioning Group, and the changes in the commissioning landscape will come into force from the 1st of July. I can't let the board pass without going on record to give my thanks to Jeff, Hilary, Anthony, Lauren, Jim, Rahul. I could go on. The senior leadership team and colleagues at Morecambe Bay CCG have been and will continue to be an integral part of our place-based delivery, Bay Health and Care Partners, and the services we all provide to communities across Morecambe Bay. We don't yet know how the boundary reviews will change some of the structures that we operate in, but I was at a community development workshop last week with 50 colleagues across all sectors, and what featured in that room was the Bay Health and Care Partners voice, and that will not stop as a result of any boundary review. So, Jeff, it's just a personal thank you from me and the board to colleagues at the CCG. I know it's been a difficult few months in the transition, but the quality of leadership and the contribution and the legacy that's been built up to this point is there for all to see. So a thank you from me. From a trust perspective, there is a nice golden thread because it's a lot of the focus for us is on elective recovery and urgent care improvement in particular. And Leanne will talk specifically about urgent care improvement today on the agenda. Also financial improvement and financial sustainability, delivering the SFIT programme. And again, Chris might say a bit more about that under the IPR agenda as to where we're up to financially. Again, on the agenda, you'll see the updates we've got around some of the key improvement activities. So a lot of focus this month on progressing the recovery support programme work streams and our key quality improvement work through things like our CQC must-do actions, the maternity improvement programme, and some of the work we're doing across the fundamentals of care and the quality and safety improvements. We've also spent a bit of time this past month on making sure that operationally dealing with the pressures, we are using our teams and our escalation levels and the site-based leadership structures we have effectively. And I just again want to recognise to the board the efforts and the tenacity and temerity of our clinical and operational colleagues in dealing with what is still a highly pressured operational environment. We did have to call our highest level of escalation again earlier this month at 04. Again, we managed to step down across both sites over a 24, 48, 72-hour period, entirely down to the leadership of the teams across the partnership, primary care, community, mental health, and our own trust. So I just put on record my thanks for that. It's an exciting time for us. We're launching our strategy. There's a series of workshops and communication events. The board approved earlier in the business cycle the purpose, vision and values and strategic objectives. They are now going to be cascaded and communicated across the organisation. And there's a reminder in the paper of the themes of the strategy and the 3 key areas of priority this year. I'm going to end on another thank you, Chair, if I can, if that's all right. So I just wanted to recognise one of our nurses, Cherish Otto, and for those of us that know Cherish and have worked with Cherish, I've worked with Cherish a little while now through the anti-racism agenda and the bullying and harassment work groups. She is a power for good and a force to be reckoned with. So I was absolutely not surprised when Cherish won 2 really prestigious National Student Nursing Time Awards earlier this month. She won the Inspirational Nurse of the Year Award and the much coveted Mary Seacole Award. So huge congratulations to Cherish. Cherish was one of the first colleagues that were recruited into the University of Cumbria degree nurse apprenticeship scheme and qualified in February this year, and we snapped her up quick smart, so she's now one of our colleagues. So a great success for Cherish, great recognition for the scheme and also for the organisation. So I just wanted to put that on record, Chair. But that's it from me in terms of an update, Chair.
Thank you. Any questions for the Chief Exec?
Yeah, thanks. Yeah, I noticed that about Cherish in your report, and pretty stunning recognition that nationally. So I've just got one question which relates to the vision and values and sort of our key objectives. And you say in your report that for each of the what I would call the we will statements or the sort of broad objectives under each heading, we'll identify what they mean in practice and how we'll measure our performance to know if we've truly made the improvements for our patients and colleagues. And it'd be useful to have that sort of level of detail shared with us at some point, so that, because I think it's quite important to see what sits underneath each of those high level objectives, and particularly how we think we're going to measure that we've actually got either achieved it or got some way towards it. And so I think that would be useful. Not that I'm asking for necessarily a detailed paper in the public board, but it would be useful to understand that.
If I can, so much of this then feeds into our annual plan delivery, which features in the IPR or board workshop or items on the board agenda. So I think what I'll do, Hugh, if that's all right, I'll work with Suzanne Hargreaves to pull out just a simple table as to where this sits and where the board will see the papers in terms of that. So I'll make sure we take that action.
Yeah, and I think if obviously it's sometimes a little bit difficult from, I mean, the IPR is improving immeasurably, but sometimes it's still a little hard to sort of see to get the overview of it from wading through the wading's not the word, but you know what I mean, sort of taking yourself through the IPR. So I think that would be really useful just to have just the way my head works. I just want to like that overview.
So we'll do the, I'll call it the cause and effect table of what we're expecting to see change and where. One of the other pieces of work that we've done recently, Chair, is the executive team have looked at a strategic review process. So colleagues will be aware that every quarter we do a slightly different report, which is to lift us out of the IPR and the operational detail and get a sense of, you know, some of the key themes or governance and risk issues that we face. Once every 6 months, we'll be working on a strategic objective review, which will allow a deeper dive for the board to check in as to the cause and effect of these actions delivering what we expect. Because for some of these, they won't move monthly. We'll need to take a different lens through that. So we'll be doing that from October this year.
Okay.
Thank you. Okay.
I was just going to say here also, as we do the clinical strategy work, those have been threads that come through that we're applying. So we will see some more sort of at that service level, eventually tangible sort of applications of those.
It's that patchwork, isn't it? So that you can actually sit at this level and see the patchwork and see how it all makes sense. So it's
Okay. No further questions. Okay, then we move on to item 52. I am aware that one or two colleagues is feeling unwell this morning and they're coming on Teams. I won't name those colleagues, but don't worry if you feel even worse. If you want to leave the meeting, etc., we'll fully understand. And if there's any issues you want to raise, just email me after the meeting. I'll pass your questions on to the relevant executive colleagues. But, thank you for making the time to come into this meeting. We'll move on then to the head governor's update, item 52. If Lorraine isn't here, I'm going to ask the company secretary to address this item.
Can't see Lorraine in the list of attendees on screen, Mike, so we'll assume that she's not here. What I suggest, Mike, is that we'll receive the report as is stated here, which essentially covers two parts. Recent work of the Council of Governors together with a look forward to July 2022 would suggest that the recommendation is accepted, but just maybe give Lorraine the opportunity to speak to this report later in the meeting if she's able to attend.
It's fine. Colleagues happy with that?
Yep.
Great, thank you. Item 53 then, we're on to patients area now. Recovery support programme with Deputy Chief Executive.
Thanks, Chairman. So taking the report as read, I will just pick out a couple of items from the report, as obviously recognising there's a separate session planned on next steps and preparation for the forthcoming national RSP system review on the 14th of July. We have used the report to provide the board with information on the output of the first application of the programme change control process. Now, it's quite important to highlight because in previous report in April, we described a rationale for some changes to originally defined milestones. It's important we had a process in place to manage changes where they were appropriate. The report that you've got today just is an articulation of the first application of that process, but is actually applied to the issues that we reported to you in April. The report also provides positive updates and information on the progression of the work stream, specifically drawing out recent developments in relation to mortality and the culture and OD work stream. Within the executive summary, there are a number of programme risks which have a targeted review date, the 30th of June. So as that's tomorrow, I'd just like to provide a couple of short updates so the board's got an up-to-date perspective on that. So in respect to the risk of recruitment to RSP funded roles, I can report we have actually struggled to recruit to the clinical effectiveness lead role, which has led to consideration of some other options for the leadership post. So it's going to remain on the risk register, but as board will be aware, Dr. Hawkswell is supporting medical director with these work streams in the meantime. So it's not an unmitigated risk. The report following the review of the trust quality improvement methodology is almost complete. Therefore, the risk remains present at this stage, but the purpose of the review, of course, is to ensure that we're best placed to mitigate any risks like that would arise, and it will enhance the programme accordingly. There's been significant activity in respect to clinical lead appointments since the last meeting. I'm sure Jane, as medical director, can provide you with a long list of updates on that, so I won't replicate that. We are working to manage the risk of retirement of the programme director. It's worth noting Claire Alexander's worked in this organisation for a long time. She's retiring. She's not lost to us because she's going to continue supporting aspects of the recovery support programme, but is stepping down from her programme director role actually tomorrow. We've successfully made a very strong appointment to the assistant director role, which in part will replace that. And as I said, Claire will continue to support key elements of the programme, thereby enhancing our capacity in any case in that regard. No, it's in respect of the niche programme, CQC and T&O components of the work streams. Just a couple of points in respect to the main report. At paragraph 3, we identified 2 projects for which delivery status is still to be confirmed. Just need to clarify a couple of points there. So whilst the report states that initial funding proposals had been rejected in respect to paediatric assessments and pathways from A&E, it's more accurate to state that the scope of work has in fact widened. From that initially proposed to the development and implementation of a service model which enables consistent and sustainable delivery of those services in the future. We can provide more information if the board would like on that. And in respect to the second item, frailty pathways, that work is actually scheduled within trust capital plans, and we're expecting works to commence in October. The detail of proposals and final business case documentation is still being prepared, hence the highlight in the report. Chair, happy to take questions on that.
Thank you. Any questions? I'll go Sarah.
Thanks. A couple of questions, thank you. I wanted to ask about the PEDS work in particular, and I know this is also picked up from Leanne's item later, so I don't mind where it gets covered, but I just, in the plan going forward, it suggests that that won't complete until 2024. The recovery support programme is aiming for coming out of that by the end of March 23. So is there risk in that delay on the PEDS work? How is that going to be mitigated? What does that look like?
Chris. Yeah, it's just in terms of the paediatric assessment work, the expansion of the scope covers the 70 standards. So it's the standards that are set by the Royal College of Paediatrics for Child Health that look at standards for children in care in emergency care settings. So obviously important given we look after patients in an ED to do that. So the piece of work we're wanting to do is to assess our compliance against them. So it goes more than just beyond what the CQC identified, which was specifically around training and staffing levels. So it's quite focused. So obviously those will be managed through our CQC improvement plans within the care groups around staffing, etc. This is a much wider piece of work, so shouldn't risk the exit in terms of RSP being picked up through the CQC specific actions. This is much wider in terms of wider paediatric assessment, so should complement it if any.
Just a point as well on exit criteria. The exit criteria is more nuanced than everything complete by a date. We've prepared some information for a discussion later today where we'll be able to explore that sort of issue. So exit criteria is often achieved by having a robust plan that you can demonstrate is being implemented and so forth, Sarah. So we can work through components like that.
Yeah, okay, thank you. And I had a second one, if that's okay as well. So just on stroke, it's really great to see the progress that's been made. Obviously, the focus is needed to be put on that because of Section 31. And so my question is, have we identified, and I know we've talked about this at previous boards, actually, it's that application of learning. Have we identified other critical pathways where we really need to look at those pathways and say, what have we learned from stroke and what do we need to apply elsewhere around those clinical pathways?
So, well, a lot of what we've done around stroke is sort of apply how we've gone about stroke to the other pathways that we've got there. There is lots of learning within that team, within that care group. Sorry, you just remind me what your question was.
Yeah, it's so we've put a lot of focus on stroke because we needed to, and we've identified key things that we needed to do differently. And I know that's partly because it's stroke, but have we then thought about what are the other critical kind of services where we might need to take a similar forensic approach to make sure that we continue to provide that best service?
I think we've focused on the ones that we knew we had issues around. I think we've changed how we approach any service that we need to address, I think is the biggest learning we've had of how we go about it with sort of that clinical leadership. I don't think we've gone through a specific process saying, let's look at this now, how do we learn from stroke to do that? I think it's probably the first answer. I don't know if you want to know more about that.
Yeah, I think rather than sort of service specific learning, I think though what we have learned from stroke is the approach to how we lead to an improvement in a particular service or a challenging area, in so much as it's really important to get the clinical leadership, really important to how we set up an infrastructure to wrap around that, how we go about providing reports that would pass muster if passed into external scrutiny, how we really understand and use data and evidence to quantify actions and impact that they're having, because historically we've not been that good at that. And also some of the learning across the wider ICS and learning from best practice from colleagues through much wider than just the work we've done around stroke internally, but the work we've done as part of the ISNDN, the Integrated Stroke Network. So I think all of that's probably much wider learning that you could apply that sort of rigour to multiple different service lines. Some of the key specialties that we are looking at, obviously TNO and neurology are part of some of that learning also. But that sort of is more the approach. I've certainly found that really learning for us in terms of how we approach some of that improvement.
Thank you. That's what I was trying to say, but not living through the equipment.
Do you want to come in now? Or?
No, Liam, pick it up.
I'll go Adrian, then Jill.
Thanks, Mike, and thanks, Chris, for the update. I've just got a couple of points. I was reading the reference pack with real interest, and it's really useful just to see the depth of activity. Looking at the individual work streams, some of them are really helpfully annotated with completion dates, but quite a few aren't. Quite a few have actually got TBCs, so that did raise concern with me, particularly if we're talking about pace and accountability and oversight from this board about how we can do that. So that's my first point. My second point was really about the recruitment to the midwifery post, and we discussed this at board previously. And I did note in that work stream, that first work stream around the regulatory requirements, it was actually raised as an alert, but to board it only appears in our report as an advise. And I am concerned in terms of the report highlights the issue, but I don't see the strength of the mitigating action. And I'm just seeking your assurance that those mitigation actions are in place, they are effective, and we are going to be able to turn the dial on this really difficult issue. Thank you.
I'll ask Chris to speak on the RSP and Bridget for maternity, if that's okay. Chris?
I think that the nature of a programme of this scale and which evolves in the way that this has, that it's inevitable that we will have to report TBCs where there's a work in progress to define that. That said, what we will do is just look at how we provide assurance about that is an ongoing process that isn't contradicting the exit criteria, expectations and ambitions. So I'll look to supplement reporting in the future to pick that up.
Thank you. I think what's probably underlying Adrian's questioning, do the TBCs indicate either a drift or a slowdown in the time scale?
So if we felt that there was an overall risk to that, we'd be escalating that as a specific risk on the programme. And also, like I said, we're doing some work in the private session later to go through an assurance process that's been led by Region and our intensive support team colleagues about our progress within each work stream against that identified assurance exit criteria. So we're not escalating that as a specific risk at this stage, but what I recognise I will need to do is give you the information that validates that rather than a statement.
You like that, Adrian? Okay, then Bridget will come in on part two, your question about maternity. Richard?
Thank you, Chair. So yeah, in terms of using the AAA report, the alert is assessed, and then if the mitigation is felt that it is appropriate, then it's an advice. However, we'll be alerted next month if it's not satisfactory. But for assurance for the board, and you'll note the changes in the maternity reports. So maternity are required to present anyway through right up to trust board and through quality and safety committee, and the report's already got the requirements required, but is further strengthened every month with the detail for board members around that as well. So it's reported through RSP, but also mandated through the work of Ockenden up to board in both part 1 and part 2, if that helps.
Thank you.
Thanks, Adrian. I'll bring in Jill, then Liz, and then Steve, and then Hugh.
I just want to talk about Claire Alexander leaving, because that is a big risk, and thanks Chris for mentioning it, because she's been so instrumental to actually driving the detail of the improvement that we've seen, and I'm very pleased that she's still going to be around to input, because her energy will help. And I want to just link it with, I did a visit last week to Westmoreland General Hospital, and just happened to meet some staff from the urology team who were talking about what they're doing to address the backlog in recovery, and how they're working. Now, I did it on a Friday, and how they were working at the weekend, and how positive the teamwork was about their working, that they supported each other to address recovery, but they volunteered to work on a Saturday. And the teamwork and the positiveness was really commendable. And that's so very different to what we've heard of urology before. So I just wanted to mention that.
Thanks, Jill. Good point. Actually, it helps with the board's drive towards assurance in that area. So thank you. Liz, then I'll bring in Steve, then Hugh.
Thanks, Mike. And thanks for the reports, and to everybody involved. There's huge amounts of work going on here, and very detailed processes and changes and layers, which to a sort of non-clinician as myself seemed hugely complex, and no doubt will be very reassuring for our esteemed colleagues at NHS-INE and everybody who'll be doing the review and being involved in the review mid-July. But my question is, how do we make this real for the changes, to demonstrate the changes that patients and their relatives are hopefully experiencing, from how things were when we had our CQC inspection to how things are now and what is still to happen? But if somebody could sort of talk me through how we can demonstrate that.
So I've just written a note to ask the chair if I could come in at the end. This is very similar, Liz, to Hugh's point on our strategy and annual plan deliverables. And I've just been thinking, as I've been reading through the papers the last couple of days, about the connections to the so what answer. So we have got a number of metrics and indications of evidence in the RSP report, but you'd have to go through the reports that we produce at the board to go and find some of the answers to the questions that you and Hugh were posing. So what I'm going to propose is, working with Chris and the RSP team and with the executive leads, whether we can have some kind of connection on the RSP report to point the non-executive directors and the board to which report on which item of the board agendas you will see some of the evidence start to show. So whether that's the IPR or whether it's the quarterly review, just so we can start to show that cause and effect of the so what questions without having to go through the detail of every work stream update on the RSP. Because actually a strength of the board assurance should be that our composite performance reports and the updates should pick up the impact of the RSP. We shouldn't have to bring separate reports for each work stream, but we're doing that because it's a programme of work. Now, what we'll actually see is through things like, the IPR for quality and safety metrics under the fundamentals of care, or when we run staff survey results or similar for the culture and leadership development work being progressed, or when we see the financial performance improve because some of the work we've started to take forward on things like the clinical strategy and clinical models, that is how we'll start to demonstrate the evidence of either patient or colleague impact on the service. And then we've also got a number of other areas. So we're talking about some audit work that'll deep dive when we talk about exit criteria. And then we've got our standard kind of review points as a trust board where we can start to draw out some of this in the way that I've said before. So it's not an easy question to respond to other than to construct, I think, some board agendas that'll start to get those answers through without the need to go into specific workstream updates, if that makes sense, Liz.
Yeah, sort of, yes. But I'm thinking more on the lines of from the patient's experience, because that's very much going back to metrics. This is more about how it feels, how they're experiencing, you know, both sort of physically and mentally to go through our services, that the whole sort of softer element of it.
Sorry, Liz. So I think my response would be similar. So it's things like the friends and families tests, or where we see complaints and how, so there will still be pointing towards the metrics, that the evidence that we would say, because we could say we've been out on the wards and we've had a chat with patients or colleagues and it feels much better, not dissimilar to the way Jill just had, which is really good additional evidence, and I'd encourage board colleagues to engage in that way with the service because it will help answer some of that question. But we'll make sure that there's a cause and effect narrative, so the evidence, the data that we can say actually experience of our services is improving. It will be in the board items that we have on things like friends and family and survey results.
Okay, thank you.
Richie, did your hand go up because you wanted to come in?
I'll certainly, Chair. I think Aaron's probably covered most of it, so I'll we can move on if that's all right.
Okay, thank you. Steve?
Thanks, Chair. And I was really pleased to see the progress in establishing the frailty intervention team, which is something that the organisation has been trying to do for a number of years now. But because I don't think the most recent business cases have come through Finance Committee, I just wanted to check that the increase in establishment that's mentioned there is actually included in our current operational financial plans for the year.
We specifically included that as an identified cost pressure, Steve, in terms of the staffing, but the business cases are more about the infrastructure.
Thank you.
You?
Yeah, thanks, Chair. I've got a couple of questions, then one sort of more minor point. I'll just start by saying that I was really struck by the frailty work, and I think Jeff will probably agree that can like to have a really beneficial effect on our primary care colleagues as well. I think that's really important. Couple of questions I've got. One is on the back of something that was just mentioned earlier about the failure to appoint a lead for clinical effectiveness, which I suppose to me raises just a few alarm bells because it's such a crucial area for us, and it possibly concerns me a bit. An organisation our size is unable to find a lead for that area, and I think that the question that then immediately comes to me is, I mean, we can't be the only organisation that's struggling with this, and whether there are some innovative ideas from elsewhere, not just within our own ICS, but actually more widely, thinking about the work that's been done in this arena for years and years and years now. So I think so I don't necessarily want the answer to that. It's just to raise that we, as we think about options, looking more widely may be good. And the second real question was about the same day emergency care work, which is obviously fundamental to our urgent and emergency care plans, because with a proposal, we'll see 50% of our people who attend for emergency care will be dealt with without being, well, within 24 hours and not effectively being admitted. That's absolutely an enormous undertaking and a real change in people's mindset and work. And there's quite a lot of appointments that are due to actually make that happen. And the alert A3 age report has for the amber has an amber status. The 3 locums are due to start by the end of June, which is tomorrow. So I just wanted to check whether that was actually happening. And then the other 2 phases required quite a lot of recruitment by the end of August. And given the situation with workforce, I just wondered what sort of level of risk that was, and so perhaps an answer to that. And then I've just got a very minor point at the end. Okay.
So I think workforce remains a challenge. I actually don't know, Liam, do you know the three, if they actually start by tomorrow? I don't know. But I think across the board, and I'm with you on the clinical effectiveness, I think we are obviously pulling from the same pool of people as everywhere else is in trying to expand. And so I think we need to we have to put in place the plans we've got, but I think we need to really think carefully about how we can transform our workforce, because I do think that there will be a serious amount of this that can be done in different ways, but none of that you can just put in place now. That would require training of relevant ACPs, etc. But so I think we have to try with what we think we need. I think I'll acknowledge it's the same in other places I've spoken to, that it's tough to get all of those people in and incrementally increase what we can do at the time. So I think we'll get a big bag.
So I suppose around the SDEC, by the end of next month, we will have a much clearer sense of what the challenge is, and really perhaps some more information about the mitigating actions and such like surrounding that work, because it is obviously, as winter approaches, it's absolutely, we say we don't have winter now, do we? But
I don't think we've come out of winter. I think that's quite right. In terms of around the estate, what they are using is agency, so they're recruiting 2 temporary posts in between. So they are moving to expanded day cover, and they've done that on an ad hoc basis over the last few weeks. So they're gradually getting there. I do have a point of interpost and expecting that August isn't a problem. Not expecting any challenges unless something changes around any sort of sign off of contracts, but nothing's been highlighted as an issue to date. And they are using interim agencies, so it shouldn't affect then the delivery of some of the services in line with their plan. But I will double check that there's no issues in relation to those additional posts.
Thank you. And my very minor point, which people who know me well, and my aversion to acronyms. So there are lots of acronyms in this paper. Probably half of them are covered in the acronym summary at the beginning. I had to Google a number of them. SFIP, which actually is quite an important heading, could do with. I did find out eventually from reading elsewhere in the paper what that actually stood for. But you might like to know, when I Googled that, one of the ones I came up with, Sheep Flock Improvement Programme. And that actually came before I could get anywhere near discovering service and financial improvement programs. So just to add a little bit of levity to our proceedings, but just a plea that if we're going to use acronyms, we could use it. But another way to do it is just to put a footnote, and actually that's more effective, because rather than going back.
We'll take that as an important point.
Yeah, I mean there were a lot that I was struggling with.
This is a public
clinician. I was
Members of the public will and can are entitled to.
And just one point, I'm not quite sure about using the acronym C2R around criteria to reside. It doesn't quite feel right, because these are people who are in a hospital bed, and using that sort of acronym, C number 2 and then R just feels a little bit
yeah.
That's just how it felt to me reading it after I'd worked out what it meant.
Okay, thank you. We note those points. A couple of quick ones for me. I'd just like to push Sarah's point a bit further, Leanne. You listed some of the things that you think we've learned as an organisation from the stroke. I think, if I've got this right, Sarah, what you seem to be saying in your question, what have we learned that could apply across the organisation, but also ring warning bells to prevent this happening again? Because part of the RSP, the Recovery Support Programme, is that we want to get to soft 2 and above. We want to be the best trust in our ICS. So there could be learning from there that could help us embed change and keep change there, and perhaps act as warning signals for the future. So I'd just like to support Sarah's question by saying you listed them. Could you come back to the board with something a little bit more formal, say, this is what we learned from where stroke was going, and urology and maternity, and these are the things that we probably need as warning signals across the organisation. to prevent future recurrence, but also anything we can learn about that we can transfer across. And my next question is to you, Chris. There's 14 trusts in SOF 4. 4 have just recently come out of SOF 4 into SOF 3. Are the execs in touch with any of their execs?
I'm in touch with the Chief Exec, Chair. I feel pretty sure that Jane's in the group of medical directors doing similar.
Yeah, I'm in a programme with the medical directors at all those trusts.
Obviously, the insight we get from Caroline's network is tends to support.
Yeah, I think we ought to minute actually some thanks to Caroline Griffiths and her team for actually collating the information that we have and across the other sort of SOF 4 group, as I call it. Yeah, thank you for that. And we spent a bit of time on the recovery support. We're asked to discuss the report, which I think we've done, and note it. Colleagues happy to that? I was quite comfortable about going over time because some of the questions actually then move us on to item 54. So you may have had some of your questions answered as we move on to now the improvement plan progress on CQC and the Royal College of Surgeons. So Bridget, you're going to take us through item 54.
I am, thank you, Chair. So this is to advise and update the board, and I'm presenting it on behalf of the Director of Governance. This is a monthly report, and I think we took comments last month, both in terms of inclusion of what was in the report, so I'm hoping we've sorted that out. But also a lot of our debate and discussion and challenge, from rightly so, from the board was around pace and sustainability, which links to some of the previous questions. Since we last met, we've reviewed how we've got our check and challenge panels in place, specifically within care groups. And you'll note, you can see the impact we're asking the so what does that mean? So we've actually accelerated some of our progress in terms of sign off between May and June from 3 to 27, which is assuring. However, the further rigour within the report, you'll notice on page 61 is actually, whilst we've approved numbers in terms of being assured, there are some that actually in terms of actions haven't been approved, because actually we want further confidence around the sustainability piece going forward. So I actually find that certainly assuring. I think also we touched previously on Chris's report and RSP. We've given the expected review of niche specifically. We've got a focus, task and finish group designated to niche. So we're starting to split out some of this work, and I think that's important. So we've put additional support in, and we talked a little bit about Claire Alexander and her function. So she will be returning to run and support the niche programme specifically through a task and finish, which is chaired by myself or Richard. So I'm really pleased about that, so that we'll be able to report through to the board specifically on niche as we start to prepare for our review in October, November. I'd also like to draw the board's attention to page 63, which is the criteria for success within niche. So we are aiming at a minimum of level 3. And the reason I point that out is because the way that they assess is different language, and we've touched on that in terms of it being a public board. The language is level 1, 2, 3, 4 and 5, and a minimum of level 3 for compliance, whereas the Care Quality Commission, in how they assess us, is must and should do's about regulation and whether we're compliant. So I do think that's important. The second thing that we've had is the CQC, you'll note, draft report, which is in the organisation. Now, this will help form and test our progress against last visits. So in terms of our should and must do's, it is a real good litmus test in terms of progress since they last visited, and that will be used for both learning in the medicine care group and also within accident and emergency specifically. And we're also expecting, and you should expect in the next month or two, for the board further reports related to the Royal College of Surgeons, and that will form part of the reporting here. And the final bit for me is that we can start to see really clearly, and in terms of some of the line of the questioning from the board, it'll corroborate with that. But we can see clearly now in terms of there's 8 actions that we're advising that won't be compliant by October of this year. And there's a number of reasons, and we can start to see those. I think that's really useful because it, as I say, it corroborates or joins up the dots in terms of other themes that we're discussing, such as urgent care, RTT, etc. And I think for us as a board, that will provide real clarity over the next couple of months, really, in terms of where we either need to focus our attention or actually there's a system response to resolve some of the issues. So I'm very happy to take questions, but the paper is to advise and update the board this month. Thank you, Chair.
Thank you. Sarah?
Thanks for the update, Bridget. And I understand Richard's not here and you're sort of covering this item, so maybe we have to sort of come back to it. I was a bit disappointed to read that part of the niche recommendations, or the recommendations having NHSEI had reviewed some of the evidence and given some feedback on it, and that some of those recommendations were around strengthening the governance structure and accountability framework, which, given the focus we've had on that, felt a bit disappointing. But I think my question really is therefore what is required to strengthen it, and how will we know when that's complete and having an impact?
Thanks. That's a really good question. So I think part of the work is, so it was really important to get an early assessment to see in terms of level 3 to level 5, Sarah. So that's whereby we've brought in additional and dedicated resource to focus specifically on that. In terms of the process around the governance, so whilst I think in terms of whilst we had assurance around the minutes around all the work that's been undertaken in terms of us getting to level 4 and level 5, and there's further work that needed to be done. That work's in progress. We are in a process of just refining and retuning some of the care group governance processes, and that's part of the NHSC and work that's been undertaken in the RSP programme, and Becky is supporting us with that. So that's linked firmly in with that. So I'm personally assured in terms of the changes that have been made last month in terms of how we assess ourselves against that. And that's certainly why we've made a dedicated space in terms of assessing through a weekly and monthly task and finish as the evidence comes in. And just like to remind the board, there's 60 recommendations alone within niche, and as we test each one to sign off for compliance and ready for assessment, Sarah. So there's a lot of work being done and to be done, and that's why I wanted to clearly have it segregated and so that the board can see absolutely clearly.
Yeah.
Thanks, Sarah. I'm going to go Jill, Phil, and then Hugh. Jill?
Thanks. We had a good go at, as we always do, this report at Quality Committee last week. And at Quality Committee, we'd asked for examples so that as a Quality Committee and now as a board, we can actually see what sign-off actually means. And so I just draw people's attention to page 70 and the case study, which is talking about the recommendations about risk registers and how they're done. And this is the kind of thing that gives me assurance that we might know if there's another stroke problem or a problem with one of our other services, because this system was tested before this recommendation was signed off in terms of identifying the risks and making sure that there was mitigations in place and that the governance around risk was robust enough to identify this. So it kind of answers some of the questions, that case study, about how we would know in future about these risks, because one of the problems with stroke is that we didn't really, as a board, know till too late, and that's been some of the problems with some of our other areas. And we can sort of say, oh, well, it was the pandemic and everything else, but actually it was those weaknesses in governance which have been addressed through this case study. So I just draw your attention to reading that bit. And at Quality Committee, we were challenging about getting detail that in the form of case studies that told the story of improvement, not just, you know, oh, well, we've done this recommendation and that recommendations. And the case study gives you some idea about the work, how the challenge was and how it signed off and what difference it makes. So just wanted to say that. Thank you.
I think it adds to the response to your question, Sarah. Thank you, Jill. Okay, Phil.
Thanks, Chair. Yeah, it was just, first of all, thanks to Bridget just for recognising that we've got the draft CQC report. So whilst it's draft and not for publication at the moment, just for those who attend the board and or aren't familiar with the process, Chair, I just wanted to point out that we're not in control of the publication of the report, but once the CQC have finalised, and I'll say final again, finalised the final copy, they'll give us a publication schedule, which we'll share with the board governors, members, and our 9,000 colleagues, Chair.
Thank you.
Just in case someone's looking for it, it's mentioned, but where is it? It's clearly not in their position yet to be published by the regulator.
Okay. Thanks, Phil. That's a good answer. Thank you. You?
Thanks, Chair, and thanks, Jill, for raising one of my points. I had to give my fairly short term apologies for the quality committee. My clinical program suddenly changed. But so I would have possibly asked these two questions there, Jill, and they may have been addressed. But I think the first one is important for the board, because last time we heard about the first support and review panel that had taken place in surgery and critical care. We got a very positive feedback, and we discussed that at quality committee. I'm aware actually that we've now had two, what I would call very heavy duty support and review panels, where in the medicine one, 41 actions were reviewed, and then in the women and children's one, 24 actions were reviewed. Now Richard's not here today, so but I don't know if anybody else can give us a sense of how those panels felt and went, because obviously there's the idea that we want them to be supportive but challenging, and there's an enormous amount of work going on in those panels. So that was my first question, and I've got another point about the report that Jill mentioned, but I don't know if anybody can give the board any sense of how those went. Richard?
Thanks so much, Chair. So they need to be supportive and challenged, but most of all effective. And I think that's the bit for me. So you'll see in part of the appendix, the progress, which I think is important. But I touched on some of the actions that weren't progressed. You will note also there's a newish addition in terms of the actions or issues log. So I think what we've acknowledged, certainly the pressures which we've described certainly last month in terms of particularly to do with medicine, that whilst they have progressed, there are some areas that they need further support with. So I think that's fair. So it's that they are really robust and very challenging in a supportive way. But the most important thing is we need outcome and effectiveness. So in terms of assuring the board, we need to be assured not only in terms of has it been completed, but have we got sustainability? And I know certainly Sarah's line of question is right around how would we know going forward. So that's a mixture of our governance processes and also effective reporting through our performance review and IPRs. So that's whereby if things haven't been passed, that will be the reason that we're actually testing ourselves for consistency. So that's certainly the feedback that I've had. Going forward, as we start to move through some of these panels, Jane and I will also support periodically in terms of a further check and challenge in them.
Yeah, I accept, Chair, that the effectiveness is the key thing, and obviously if this is part of the way that we want to work going forward, there is also the soft side about how they actually feel to staff who go through them, and I think that's probably what I'm getting at, because obviously we want them staff to feel this is a really positive way of doing things, and you know, and I'm not saying this is what happens, Bridget, at all, but the converse could be true, that people could come out feeling I've just been sort of hammered in that, and so I think it's that sort of thing I'm trying to get at, and maybe some conversation with you and Richard outside would be good. Yes. So I'm quite happy to follow that up, particularly with Richard afterwards, because the feedback we had from the first one was actually really positive. So I just wanted to check when the ante, if you like, raised with all of this work going on, that it still felt.
I'll bring Jane in, because Jane's got hand. I assume you're responding to.
Well, yeah, and it's not about these panels as such, because I've not been in them to be able to feed that back to you. But I think what we've found in all of the meetings we've gone to, there is at first there will be a little bit of a shock, but actually people have responded really well, that they know what's expected of them, and that the boundaries and the parameters are clear, and so we've seen, certainly in some of the incident review groups, etc., we've seen really improved work that's come through, because people know what's now expected. So I suspect it will feel the same. Yeah. I guess there will be some that need more support, because it will be a bit more of a shock perhaps to them, but I think people have responded really well to these things.
Richard, coming back.
So So I think what we can do around that, so I'm certainly confident around it, but what we can do, a bit like committees, can put an effectiveness in. So effectiveness evaluation at the end of each committee. So then everyone who's taken part, so that can be reported through this as well. I think that's probably the best way to deal with that, and then it's both transparent and it's seen up through quality committee, etc. If that seems reasonable.
Yeah.
Okay, thank you.
And the second point I had was I agree with Jill that the appendix actually gives us an example, but I'm afraid it did leave me with a so what feeling to it. The reason being is that I think it was the CQC recommendation was that was about identifying risk register and risks that are supported by robust action plans that can reduce or mitigate the risk. So I read that we developed a really good process for identifying the risks, but I feel that going forward, this sort of example would be really strengthened by maybe an example of a risk that then had been mitigated or had been reduced, and that was actually then described that through this process we identified this specific risk, and these are the actions that we put in place to mitigate it. And it would just really bring that alive to me, because it felt very processy, that example, that we've got all these processes in place now, we identify these risks, which might take us a step forward from where we were before. But actually what we then want to see, it just even perhaps one example of this was a specific risk we identified and we did this. And I would have raised that at quality, Jill. So and I don't know if it was discussed at quality in that way, but I think given the discussion we've just had around this whole area, I think it's that sort of
we hear it.
Yeah, that really gives me something that, oh yeah, I understand that, I can picture that.
Yeah. Bridget, yeah, we'll take that as a recommendation from you.
Jill Scott.
Jill, and you'll take it through quality.
Yeah, I'm quite happy to do that, but I just wanted to say, just for, because maybe not, I know Hugh may not have been here when we actually did the audit about what went wrong with stroke. And it was the fact that we could have done these actions sooner and earlier if we, the key people, had known about it in a timely way. So although it does seem a bit procedural, this example, it gives me assurance, because that was the very problem before, that we didn't know about it, because that's what we addressed with stroke. So I think we need to, and I guess that's why CQC made that recommendation, which sounds a bit administrative. It's a governance thing, it's about risk register, but actually it's about the board not knowing what's going on. And that gave me assurance, because the process was in place to make sure the board did know.
Thank you.
I accept that, Chair, and I really agree, Jill. I'm just thinking we could take that a step further.
Yeah.
Which then comes alive to us by seeing just one or two examples of a risk that's got a plan and has been mitigated. This has been done, and it takes us that next step, doesn't it? Yeah. So obviously it gets us to step one, but actually let's see the next stages.
It's probably a dual point being made here for executive colleagues, really. The first is, I think we're talking about the process, and you're providing some information about how that process is developing. And then the second issue is the so what question that Hugh asked. So, is this being embedded? Are there things in place to prevent it happening again? And exactly what is the impact for patients? Where is it, even if it's governance? So there's probably a dual dialogue simultaneously going on that you execs may wish to consider, that when they present reports, that we go, yeah, here's where the process is and where we're up to, and then here's how we're stopping anything going backwards and any mistakes from the past happening again. Here's the impact on patients.
And I think, Chair, Aaron said that if the papers were, several of the papers were included, some of these really positive examples of things that have changed, clinical things that have changed for patients, as we as execs read them, we would then get this feel scattered through several of the papers that that's happened and that's happened, and it's just as Aaron described. I think it's
through quality,
yeah,
perhaps,
through quality and through here, because I mean, once they're here, we don't need to then we don't discuss it, we just acknowledge it and say brilliant.
Okay. Colleagues, I've got a couple of questions from me, but I'll just check now. A couple of quick ones from me, Bridget. One of the histories that this trust has got is always responding well to external reviews, meeting the recommendations, getting a little tick from the externals to go, yes, well done, you met the recommendations. And then 2 or 3 years later, having to go through the same thing again. So we probably just need, as we develop these areas around CQC, niche and Royal College, some assurance as we go forward that this is being embedded. And as we move out of soft 4 into 3 and then 2, become a good to outstanding, you know, what are the mechanisms that will warn us, number one, if we start to slip back, and number two, yes, these are embedded. So that's, it's not a question, it's just an observation. And then my other one is a question to you, Bridget. One of the things the CQC have said is that our pace, I recognise all the pressures that we're under, and I recognise as well, and it's a point that Aaron's well made in the past, you don't want to rush things so that you have a superficial appearance of dealing with it. Some things necessarily take longer than others to make sure we embed it. So my question to you is that, you know, the bits where you say we're behind schedule, and I know that some of that is the support and review panels going, not happy with what you've given us, go back and do some more work. But are you confident, or can you give us some assurance that as we slip on these timescales, that progress is still being made?
Thank you, Chair. So there's a couple of bits for me, and it's really important. So what I'd expect in the report going forward. So I know what it's in the question, but it really matters in terms of the well-led for the organisation, in terms of if we knew, why didn't we do something about it? If we didn't know, why didn't we know? Which has been a theme. So the key things around that are the accountability framework, the governance framework, our reporting and our escalation processes, and how we do our business in the organisation, irrelevant of subjects. That's the first thing. So that's why the work that's been done more broadly is so important in the sustainability question. The second thing, in terms of what I'm expecting in the report going forward, so what my ask is around the sustainability. So if something's been discharged to business as usual, irrelevant of whether it's in the RSP or in this function, actually, we need to know then, where is it being monitored and how do we know? So how have we essentially nailed that down? And I think that's where we're going to get our assurance, Chair. So am I assured currently? Yes. However, what I want going forward is to be really clear on every aspect of it. Where is it being monitored as business as usual before it's signed off? And it shouldn't be signed off until it is, because we need that assurance. And I think that will help in terms of the sustainability and the well-led aspect for the organisation. So I'm trying to think of a real simple example. We've just described something in the, and I know it certainly needs work around the risk register management, but we need to be ensured in our governance processes that risks are managed appropriately, that they're actually being assessed, that they're actually seen through care group up, that we've actually got sight that it's escalated, it's been monitored through our performance review panels, and we've got an escalation process. Will be a good example, irrelevant to the subject. And I think in this next 6 months through this report and other bits, that's where we need to get to. And similarly in the RSP programme, where things are being discharged, we need to know it's been discharged to something that we see, whether it be the IPR or whether it be somewhere else, or a quarterly report. So we've got that assurance, and I think that's the sign-off process that we need to work on for the trust. That would be my recommendation.
Thank you, Bridget. I'm going to ask Chief Exec to come in.
Just on a similar point, so there's a theme building this morning, and I'm just a bit cautious about the level of detailed information that might start to come back to board as a result of some of the discussions we've had. So I'm going to take an action to meet with the executive team about what recommendations would we make. We're not going to be able for every paper in every area to do purpose and impact and sustain. You'll end up with hundreds of reports. So, and I think one of the reflections for me in my 7 years here is that is it's ringing an alarm bell with me, because it's part of the cycle of the board's own response to pieces of work where we're trying to pull back and then we go back in. So I'll have a think with the exec team about how best to satisfy the board assurance documentation. But one of the reflections I'd give is, without teaching grandmothers how to suck eggs now, the difference between process and system controls assurance and assurance of particular line items of work streams and updates. So I think, Chair, one of the things that might help around the sustainability question is we point our audit programme periodically at the effectiveness of our control systems. So rather than having to go into every level of detail on each work stream around assurance of pace or sustainability, Bridget's just highlighted really clearly the governance, the risk management and the assurance process we put in place are designed to answer that question. So the board assurance should be, well, how effective is that system then? You know, what confidence can I place in that system without having to go into every item of it? So I think what we'll do is we'll work with audit to make sure the audit programme has a control systems process assurance report, which we can then sample test.
Yeah, like a stress test. Yeah, colleagues, you happy with that? Okay, thank you. Yeah, and I think you're capturing the themes that's coming out of the board this morning. There's a number of recommendations on your report and also some comments and then one escalation. We're asked to note those. Yeah, okay, thank you. Thanks, Bridget. You're on for the next item as well. Item 58, the maternity safety update, and we welcome Heather. Is Heather here?
Cheers.
Yeah, Heather.
Hi.
Hiya, Heather. Welcome, new Director of Midwifery. You're attending to present the paper, so I'll give the floor to Bridget and let Bridget control how you wish to present, etc. Over to you, Bridget.
Thank you so much, Chair. So just to acknowledge this is Heather's first board in terms of presenting, and just to thank her personally for her work on the report, which has been revised and improved. So thank you for that, Heather, but I will leave the floor to you.
Thank you, Bridget. So this is our monthly maternity assurance report. So it covers data that needs to be covered from a perinatal surveillance model. That is a data set that we're required to report to board monthly. So that is in the appendix of the paper. So I'll take it as read. The paper covers any issues and highlights that we wish to indicate to the board. So I will just go through that. I'm conscious we're a bit behind time, so I'll take questions at the end if necessary. So Saving Babies' Lives Care Bundle, this is a piece of work stream around reducing perinatal mortality. It's also got national targets for us to meet. Saving Babies' Lives Care Bundle is actually part of Cnst as well, incentive discount scheme. So we've done a piece of quality assurance against our Saving Babies' Lives compliance, and you'll see the action plan detailed in the paper. So I would probably say for board members to note, we had previously said we were compliant with Saving Babies' Lives, and this is something we see in other organisations whereby compliance isn't really understood in terms of the actual ask of the programmes. So what you'll see there is if you actually look at the elements of the bundle that we're not compliant with, some of it is just guideline changes. So I expect that our compliance with Saving Babies' Lives will be back on track very, very soon. So, sorry, just bear with me, my mouse doesn't want to work now. The second piece of work that we've got ongoing in maternity services is the review of the perinatal mortality tool. So we had a regional piece of work done into how we normally conduct PMRT, as it's known, its acronym. There is some further work to do around our classifications of the cases. What that means is whether we classify the cases in terms of whether there's been any contributory factors that has led to the perinatal mortality. So that review is being undertaken next week by our newly appointed quality, safety and assurance lead midwife and 2 external a neonatologist and an obstetrician, so we can go through and really have a robust assessment of how we've previously used PMRT and any actions we need to take in some of the historic cases. But the PMRT process since I've been here has been amended in alignment with current national guidance to assure the board. The next thing to note is the Cnst Incentive scheme. Obviously, as a trust, we needed to pay back the discount incentive that we received for year 2 following an assessment from NHS resolution. Cnst, I suppose, sometimes can be quite challenging for organisations because, again, it's understanding the devil in the detail around the requirements. So the Cnst scheme was actually suspended during COVID. It's now been relaunched with revised requirements around year 4. But it's important for the board to note that the Cnst incentive schemes actually every year the scheme gets bigger and the requirements are in addition to what the previous year was. So as we have had to pay back year 2 of the incentive scheme, we need to do a gap analysis against year 4, but it will also need me to go back and look at year 2, year 3 and year 4 to see what pieces of work we need to do in order to become compliant. It's not just a case of looking back at the current year. So that piece of work's being undertaken to assess I suppose at baseline level what's required moving forward. So the revised submission requirements for Cnst is actually January next year. So we've got a bit of time to really understand what the ask is and what the building blocks is we need to put in place in order to be able to achieve that. We have got a WACS governance scoping and mapping exercise with support from NHSE and I and the maternity support programme next week. That is to ensure that WACS governance is in alignment with new trust governance framework, but actually fit for purpose for WACS as well, in terms of making sure the links between neonatal and maternity are very robust and where they need to be. Across staffing, so there's some comments around the staffing at the moment. So we have got some deficits in midwifery staffing that's been there for a while. We've which we are attempting to deal with, but it's also to flag up to board that there's other maternity professionals that are also experiencing some staffing difficulties. So anaesthetics, obstetric, and some codependencies such as scanning. And the reason I bring that up is because on the perinatal surveillance model, what you'll notice is we look in terms of assurance in terms of obstetric hours per month, which is pretty standard. What the perinatal surveillance model doesn't do is triangulate what the staffing actually is. So it's just to note that that's I suppose a deficit with that actual model. So that has been fed back to national teams that maybe we need to be looking at a different type of metrics around obstetric or maternity professional staffing levels. That has been picked up with the individual group. So anaesthetics, I'm waiting for them to come back around where they are and what their mitigation and plans are in terms of staffing. That feedback's not available for board at the moment because it was literally a couple of days before quality committee. So we will feed that back to the next board feedback meeting. Ockenden, we have an assurance visit from NHS England and I, and that's planned at the end of July. So we're doing a lot of preparation around getting ready for that visit. The purpose of that visit is the original Ockenden compliance assessment was very paper-based. So if I can use the example for board, like safety huddles is a prime example. So as part of Ockenden's recommendation was to implement safety huddles, but the requirement that they asked for in terms of compliance was that you had a SOP to say you did safety huddles. So the assurance visit is to come and check the actual safety actions been undertaken rather than the fact that we've just got a SOP. So there's a lot of preparation work for that. There's a big data submission that needs to be done prior to the visit. So we're working very hard to make sure we're in the best place we can be by that visit. Obviously, the board will be aware that Ockenden actually published the final part of her report into maternity issues at SAF. And the board would have probably been expecting a paper and a benchmarking document around that. We have completed the benchmark. It will be coming to board. However, The reason for the delay is we haven't yet received any national steer around what the Ockenden recommendations are to be. And what I need to indicate for that is some of the recommendations are really subjective, so they're really difficult to understand. So we are waiting a national steer on what actions are actually going to, I suppose, be requested of us. My understanding is that the Cqc report into the East Kent investigation was due to be published in July, has now been delayed till September, and the feedback is that Ockenden, the final reports, recommendations and Cqc's reports into East Kent will come at the same point in September. So although we'll bring the Ockenden final report benchmark to board for information, there will be no further action plan until that later national steer comes in September. As part of the Ockenden recommendations, there was a request to suspend any continuity of carer work streams or rollout, should I say, implementation of any continuity of carer if there was any midwifery staffing deficits. Therefore, our continuity, we didn't have any models running at the time, but that has been suspended. Now, there's still a national ask that we submit a board paper and a SOP and probably detail to the board what our plans are in order to become compliant with continuity of carer. That will come next board meeting because that's a requirement for the LMS as well. But for all intents and purposes, it is suspended until we get the vacancies at a much lower level than they are. So that will be coming for information. And I would probably stop there unless we've got any questions.
Colleagues? No. I've got 3 questions. So, yeah, 3 quick ones from me, Heather.
Yep.
All the national reports, including the Ockenden original report into what's going on at Shropshire, says that one of the markers that you can use around potential issues is the lack of attendance on CPD and training programs.
Yes.
The report outlines that we have a very poor uptake on that. So my first question is simple yes or no. Are steps being taken to improve the attendance on our training program? So it goes up from that 35%, and by when?
Yes, so we have a training plan specifically targeted at those professionals with lower compliance, such as the obstetricians, and it's got some trajectories in that for achieving compliance. The requirement is 90%. I think we also have to be mindful is nationally we're struggling to achieve anywhere near that level just because of the workforce challenges across maternity services. So there is a plan, there is a trajectory, and I think it would be in the perinatal surveillance model, it is highlighted every single month. So we will keep a close eye on it and escalate any further concerns. And I think for me, it's really about trying to ensure that the training's targeted around the stuff that really needs to be done.
And then there's a couple of issues around anaesthetists. One is the compliance on prompt, which is under 50%. And
yep.
Also, just some clarification. I don't like pointing out specific paragraphs in the report because you're expected to memorize everything. But in paragraph 15, it says that the national recommendations is that anaesthetists should give 12 sessions a week on labour wards. And then there's a line that says, we've increased it. And it looks like it says minus 3.75%. So, but even if it's a plus, going from an extra 3.75%, does that mean we've now reached 12 because it was previously below 9, or are we at just under 4% and we should be at 12 sessions a week? I wasn't quite sure.
I think it's an approximate.
Yeah, I think that was feedback from the clinical from the anaesthetic lead in terms of obstetrics, because it's not normally a metric I would report myself. I will seek clarification from him, because that we have gone back to anaesthetics to ask them what their plan is in terms of mitigation and any further actions in alignment with not only not hitting the staffing requirements, but also in terms of their training compliance. So I will have to come back with a further update via quality committee on what that actually means, because I'm still waiting for their response.
Yeah, I had just a very quick question on that. It said that they report this is having an impact on patient care. I assumed it was a positive impact, but it just sort of, I suppose it relates to whether it was I assumed it was an approximate increase of 3.75, but so probably that just needs clarification.
Could the quality committee look at that then, if you don't mind, Heather? Because even if it's 3.75 sessions extra, it's still way below the 12 required on the national guidance.
Yes, that's what we agreed at quality committee. I'm just waiting for them to feedback, so it will be fed through that group.
Yeah, I'll bring Jill and Bridget in case they're responding to that.
I was just going to say we picked up these questions at quality committee and have asked for a specific report on this, which is what Heather's referring to, that she's bringing back to quality.
I'll let the subcommittee do its job then.
That's all right. Just keep us on our toes, Mike. It's good.
I'm going to bring in Liz then, Jess. Liz and Adrian after that.
Thanks, Mike. I'm sorry to colleagues that have jumped ahead of here because my hand up went up very, very late. Hi, Heather. Can I just ask, so the more we see these reports across lots of different organisations, one of the huge problems seems to be recruiting and retaining midwives, doesn't it? And a huge lack across the whole country. It's not just us. So long term, we need to get more midwives, don't we? So is there a plan in place nationally to help trusts grow and retain midwives to enhance, entice people to become midwives? What do we have any sort of set plans? And if we don't have anything coming out nationally, what can we do? And I appreciate it's not a quick fix, but we do need to start addressing this now, don't we?
Yeah. So we're well connected into the NHS England sort of direct support offer around recruitment and retention. I think for me, one thing that I've certainly observed is there's certain, if you like, gold standards, offer incentives, offer good, robust in preceptorship programme, etc. I think one of the challenges we have specifically in this trust, and particularly at Barrow, because that's where we suffer with difficulties in recruitment more than anywhere, is I can do all that, it still doesn't make any difference. So there's something about how do we grow our own within those local communities who live there, who are not commuting, etc., who are then influenced by the cost of petrol prices, etc. So there's something about seeing it as a more medium and long-term goal of actually really looking at how we grow our own, particularly at the Barrow site. So yes, we're developing a whole workforce plan, and some of that will include transformation, because getting more midwives is it takes 3 years, so it's not a quick fix. So there might be something we need to do about how we utilise the workforce we've got at the current moment until we've got that pipeline improved. So we're well connected within the regional and national programmes, just to reassure the board of that. But there is, and what else can we do that needs to be probably specifically considered for us as a trust and where we sit, particularly geographically, and the challenges that sometimes brings. So yes, loads of work ongoing, and probably when we've done that workforce plan, it'll be good to bring that to quality committee to sort of detail what work is going on, so people have got assurance around the actions.
Great, thank you, Heather.
Thank you.
Look forward to seeing that come in time. Thanks.
Thanks, Liz. I've got Jeff, Adrian, David and Bridget. I'm conscious of the time, colleagues. We've also got Wesley, I can see you there, that you're going to be talking to us around item 59. We're currently on item 55. So if you want to, you're welcome to stay. It's a public meeting. But if you want to come back at 12:10, we should hopefully have reached your item by then. It's up to you whether you can stay or you can go for a cup of tea or something, and we'll see you at 12:10. I'm conscious otherwise you'll be waiting more than an hour.
So 12:10, you want me to come back?
Yes, please.
No problem. Okay, thank you.
Okay, thank you. Okay. I'm going to go then, Jeff, David and Bridget, and push you for time, please.
Okay, thanks, Chair. I'll be brief, and welcome, Heather, to Morecambe Bay. A question which is probably a simple misunderstanding and a suggestion. I'm looking at the perinatal mortality review tool on page 76, and I'm looking at paragraph item 6, and it quotes babies at 22 to 22 weeks and 6 days, and it quotes babies over 24 weeks, whether stillborn or neonatal deaths. What's happening to the 23 weekers? Is that a typo?
Probably, yeah.
Shouldn't it say 23 weeks and 6 days in that middle bit?
Yes, it should.
Okay. Okay.
Thank you for noting that.
Right. Yeah, well, I do read some of the papers. There you go. My suggestion is, in the spirit of integration that we're moving into, in the new place-based arrangements, there will be a GP who has in their portfolio women and children's, and I'd commend you to get to know them, and some of the things like particularly like the Ockenden stuff and visits and like that, they might want to be part of that, and they might actually be helpful. I was part of stuff in the past around Kirkup, and I thought it was very helpful. I would say I was very helpful, wouldn't I? But I think the whole process was helpful to us in the CCG. I don't know who that person is because we're in the middle of reform and we don't know who's appointed, but I'd commend you to get to know them. Thanks, Mike.
Thank you. Yeah, good point. David?
In the interest of time, I'll put my hand down, Mike, so it's not an issue.
Thank you. Bridget?
Just briefly, so we're required to have a workforce plan, and that is in train. So we'll come up through both people committee, and I think we've already had a deep dive around maternity. And just for assurance, so I'm linked with both the national and regional teams. We met even with them last week more broadly on pipeline discussions, and have really put Morecambe Bay as a priority for all the reasons that Heather's described. So I'm hopeful. So, for example, the international pipeline as a priority, but also apprenticeships, and certainly the schemes and the work pulling together for the trust about what we're already doing in terms of our short-term, medium and long-term plan. So that should hopefully be ready in the next month or two, but not just exclusive to maternity, because what we apply to this applies to all, doesn't it, in terms of pipeline work and the geography which we've described. So
Thanks, Bridget. So we've got quality committee doing some work in this area. We've got people's committee. So thank you. And Heather, hopefully it's your first board. You'd have got a flavour of the type of approach we take, and recognise deep dive's been done, but maternity is an area that we're really scrutinising quite closely, as you can tell. So thank you for your report. Colleagues were asked to note it. Number of recommendations. Yeah, we all note that. Heather, Bridget, thank you.
Thank you, Chair.
Thanks, Mo. Okay, we move on to a related item, really, the Integrated Performance Dashboard and Report, Deputy Chief Exec, for the item 56.1.
Conscious of time, I won't read out large components of the report, Chair. We have continued our development of the report. You'll see an enhanced executive summary in there, which actually seeks to provide an identification, highlight issues for the board in advance. We're still work in progress to finalise, everything that we want to around the IPR, but hopefully that's useful. So you're automatically receiving the highlights. Hopefully that'll free up time to support board inquiry. Just a reminder, there are 3 further developments programmed into our development plan, so we expect to have completed our work during July to support recommendations of targets on all key metrics. which don't currently have identified targets. That will also allow completion of a section of the executive summary and the detail of the performance against target contained from September. So those spiderweb diagrams will be more complete from then. We also expect to have completed development of care group IPRs for incorporation into the trust performance framework from September. And we're meeting to develop statistically relevant finance performance information for future incorporation within the IPR. That meeting's in the near future. Dates will be confirmed after that. There was just one point we wanted to raise, just for clarification. I'm going to have to defer to my much more capable colleague to the right, Leanne, who's just going to highlight an issue about the urgent care data. Performance data.
Thanks, Chris. It's just to bring to the board's attention in terms of how SPC charts, statistical process control charts, in the interest of acronyms, are developed. They take the first 20 data points, and the first 20 data points are used to set two things. They're used to determine the upper and lower control limits. They're the dotted lines on the SPC charts, and they're also used to dictate the icons around assurance and trends. But given that, something where you'll see it most obvious is on the 12-hour breach of performance graph, where it gives an indication that we will pass that metric. But that is because it's only taken that January 19 through to August 20 data, so it's not considerate of the most recent performance metric, performance levels. Obviously, as we move into this new year of reporting, we're now obviously looking at April's data. We will be considering that, and for July, when we finalise and finesse some of those final data points, which is what I mentioned at last board, the upper and lower control limits, and therefore the data assurance icons will be corrected and take account of that more recent performance, so that we have an assurance that is more reflective of the later period.
Thank you.
Okay, that's it. Chair, happy to
take questions. Okay. You.
Just to follow up on Leanne's point, actually, it's not just that one, is it? There are several that, if we become slaves to the, I'll use the SPCC, I use the acronyms. I don't think actually the full title is actually any more explanatory. The way the statistical process works, it just uses those data, and some of them it is a little bit strange, because I think on the ambulance ones it suddenly says that we're doing pretty well on I think less than 30, and then we're failing on another one, and it's just because of the way the charts run. So I think we probably need to become smarter at the accompanying text, just to pull out that. Which I think we are, because I think it's a vast improvement. There's the legend at the beginning, which is great. I've got a minor comment I'll mention to you afterwards about that, but it's great. But I think the way we then discuss some of the issues it will pull that out, enables us to pull that out, because I think we've got some and I'm really pleased to see we've got some targets in there now, and I know that by the end of July we're going to try and get our internal targets for a lot. But then we find ourselves in a strange position that our target sits up here, and all the data and the various sort of limits sit down here, and we're in danger of saying, well, it looks all right because the limits are all right. So it's my favourite one, which there now, is the indicative review date. Sort of we say that that's a random variation when it's gone up by 1,000 in the last month. I'm not sure if that's quite random variation. So it's this sort of thing that I think we just need to get smarter at. But it is a vast improvement. There's one thing I would say that is where I corrected the minutes last time, which is about the patient safety incidents per 1,000 bed days. We sort of have that as an orange saying that it's gone up. And it's like a bad thing because it's gone up. But then we also have that the number of moderate and severe incidents are actually stable or have gone down. Actually taking those two things together, the high number of incident reporting is probably a neutral statement. It's probably a good thing, and whereas the SPCC chart suggests it's a bad thing, but actually it's as the accompanying text says, we have got a positive culture, seem to have a positive culture. It's how we get that nuanced discussion of the data out, which I think is a challenge going forward. I don't want to negate that it's such a massive improvement, it really is, but there are some nuanced things that we just need to get right, which will help us, I think, and limit the discussion we have.
I'm going to take the comments that you've given, Hugh, as helpful comments that
yes, and I'm really happy to have just a very quick chat with you afterwards about a couple of points.
Chris, you want to respond in any way?
We're continuing to work with Riley and the national team to really get that point about how you put the narrative against this. That's an ongoing piece, and actually Sam wrote to me this week about how we continue that process. So we will continue to improve.
But it is so much better. Absolutely, it's so much better.
But it's specifically to provide that context where the data can mislead, even if it's good data. So absolutely recognise that point. We're working on that. And in terms of the identification of targets, they can also look a bit odd as well. Yeah. And we've tried to apply some science to that and improvement trajectory targets as well. So the bear some relevance to where we are, rather than otherwise. So we'll make, and what we're going to do with that is make recommendations actually, rather than just say here's the target. So hopefully that'll be a useful process for you to say.
Thank you, Sarah.
Thanks. So I've got 2 points or questions. So the first one actually I think is a bit of a continuation of this around the charts and what they tell us, because I was looking at the patient safety and quality section and just noting there are probably certainly 3 indicators if we set aside cancer, which effectively you look at 2 years worth of data and say we're just not hitting the targets. And so the examples would be the incidence per 1,000 bed days, the VTE assessments and pressure ulcers. And I know, for example, pressure ulcers, there's a programme of work underway. So I think my question is really, at what point do we or can we say, actually, this really is not going to hit it, we've got to do something different? And then the second thing was to seek some assurance, probably it's Bridget, but around the pressure ulcer programme in terms of where we are with that programme and when we where we expect that to really start to come down and demonstrate that that's improving for patients.
Well, I'll take the first point again as a helpful comment, Sarah, for exec colleagues to take away and look at that, particularly about, you know, if we're failing to achieve targets 2 years, then should we look at doing something different? And then Bridget, do you want to respond to the second one? When do we expect the interventions around bed ulcers to actually have a downward trend?
Yeah, of course. So there's a couple of things. So it's set in terms of the quality. This is important in the RSP programme. So what we've aspired to is to start with a 20% reduction of pressure ulcers, whereby in simple terms, patients didn't have one when they came into the establishment and they acquire one of grade 2 and above. So that's the strapline, that's the quality improvement work that we started in January. It will also form, you talked earlier around how would we know, and Aaron touched upon that. So as part of our quality plan or quality strategy for the trust, there'll be clear, simple measures and metrics that are named within that. So an example of this would be that we'll have no grade 3 pressure ulcers in this organisation within hospital that are required, and we will reduce our hospital acquired pressure ulcers by 20%. And just for assurance to the board, that type of work is in line. I've reviewed 12 other IPRs and board papers for other organisations, so we're in line. So in terms of the work, what you can see, Sarah, is we started in January and we've got a 3-point reduction to date in terms of reduction. We track it weekly through the work of quality improvement and our harm-free care panel. In terms of advising the board, I'm expecting us to get to a stationary point in terms of reduction, probably at around 1%. I've seen the data for May and June already. In terms of advising the board, it's really important. The next piece of work will be around unstageable. So what I'm recommending or advising the board is that we will possibly see, once we've got to a point of stability and reduction, we may possibly see a slight increase. But in terms of 1 per 1,000 bed days, what I'm going to start to put in the narrative is a comparison of where we are against other organisations. The trust in the previous IPR didn't use per 1,000 bed days, we used raw numbers, so this conversion is a new way. But in terms of where we are today currently, Sarah, there will be 1, 2, 3 point, there'll be a 5-point reduction month on month statistically, and when you see the data in August from June. So that's the position we're at currently.
Thanks.
Thank you. I've just got a second question, if that's right. And firstly, yeah, absolutely to acknowledge that you can see that downward trajectory on pressure since January. So yeah, absolutely. My second one was just about the vacancy measure, which is showing us good at the moment. But what we know is that the establishment review shows that we're under establishment. So presumably at a point at which we make that correction, that vacancy indicator going to worsen, and is there anything we can do to mitigate that?
David?
One of the things that we've done with the IPR is that when we've put it together, it's been put together in a way which makes some of those data lines non-meaningful. So the vacancy figure as it stands at the moment isn't a particularly meaningful target. So it's an issue we're picking up at the People Committee, and which we will address, because that's the general vacancy figure, but I don't think it really gives the board what it needs around its biggest risks. So it's not pointed at risk. So there's just a bit of work that needs to happen on that, but I think it's as part of that natural iteration and development of the IPR as it moves forward.
Okay, thank you. Bridget, is your hand up? Is that a legacy, or you want to say something?
Yeah, it was just on that point, because I think Sarah was alluding to the establishment review, so it's worth to comment. So last month in the People Board, I'm asked, we will be going back in terms of a tracker and a projection or trajectory tool, which is just almost due to be completed, which it looks at not only the establishment review, which is really important, but also looks at our activity required. So for example, Winter, the Chief Operating Officer, and the work that Leanne's done around that will demonstrate what our need will be in terms of staffing. So that work's completed. The second thing, Sarah, absolutely. So that adjustment will be made and the gap will be seen. The third and most important thing is you're asking in terms of, well, what do we do about it? So I've already met with the regional team. So I was both discussing maternity and also specifically healthcare support workers. And there's been a lot of success in the region with NHSI on recruitment campaigns. So that works in train as well. So I'm expecting it to feed part of the workforce plan that will come up through the People Committee as well. And absolutely right to ask that.
Thank you.
Okay, thank you. Adrian, you've got your hand up.
Thanks, Chair. I just wanted to pick up on some of the comments, some of the narrative. I mean, it's great with the IPR to be able to see the long-term trend change, and I'm not surprised that appraisals and core skills are in there, as are quite a few of the others. I just wanted to pick up on the comments that accompanied the DNA that did not attend section. We consistently missed the target on that for a number of years now. The only time that we did achieve it was during the pandemic. But the narrative, the comment that was in there was quite reassuring that we were middle of the pack. And I just didn't feel that was a helpful comment to include alongside that continuous underperformance. And there were a few other narratives like that in other areas, which I just was slightly concerned about. Thank you.
We'll pick up the feedback and put it in. Just a reflection, we've spent a lot of time doing what I would call IPR report development work in the board. So something's not quite working on the iteration of the report. So I'll ask Chris with the national team if we can take offline as we draft the IPR, maybe with a subset of some of the non-exec directors as we build it. So we're not bringing something into board where we're doing IPR development work. I think we could probably get a bit sharper at that so it iterates outside the board meeting. It leaves a bit more time both for some of the inquiries on the data.
Yeah, I think overall what the IPR is showing, because the operational monthly reports, and they're always slightly behind in time, is that we are progressing. But it's patchy. Some areas are moving faster than others. Some areas hardly any movement going on. A bit like a seed bed, really. There's different plants coming through at different times, and that's what, to build on Anna's point, we need to concentrate on those areas that are not moving or that are patchy. Why they're going backwards and up and down. But not forget where we're constantly passing targets or achieving that there's lessons learned in those. So, you know, I back up what you're saying, and we need to focus in on what is it for patients, where are the issues that needs to be brought to our attention, what is the data telling us about assurance. Okay, and Wesley, welcome back. I'm going to come to your report in a second. I'll jump ahead of the agenda. I'll just deal with item 56.2 and then I'll come to you and then you can go and then I'll go back to other items in the agenda. But please, you're welcome to stay for the whole board if you wish. But just so I finish 56I, we note the report. Yeah, thank you. So 56.2 then, quickly go through the assurance committee reports. We'll start with audit. Chair of audit.
Thanks, Mike. So the report's there. It's very concise and lists out the alerts, the assurance, and the advice. Sorry, I couldn't page down fast enough on my screen. So I'll take it as read. The only other item I'd just note is that the accounts were filed on time, and it was a huge thank to all the teams, both internally and externally, for helping us to achieve that deadline. Thank you.
No questions for audit. Okay. Lorraine, just to let you know, because we talked about the head governor's report earlier on, I'll bring you in under item D on this. So I'm going to do finance and performance, quality, and then the head governor's report, just to give you a fair warning. So finance and performance.
Thanks, Chair. I don't think there's anything to add that isn't already in the executive summary of the IPR report, which points to the challenges care groups are facing in containing their run rate for expenses, mainly around agency costs, and also the challenges in developing plans to meet the very stretching CIP targets this year. But I think they're already in the IPR executive summary. Thank you.
Thanks, Steve. Any questions on that? No. Okay. Quality committee, Jill.
Much of what we talked about has been on the agenda today, but for the meeting last Monday, we had a presentation from Core Clinical and the Medicines Care Group talking through their quarterly reports, and at Quality Committee we were able to see how the care groups were addressing the CQC recommendations and producing evidence of improvement. So just for noting at the board.
Thank you. Okay. No questions from that. Thank you very much. And the head governor's report, please, Lorraine.
If I can see what I've written, I'll let you know, but my vision's very, very blurred at the moment, so you've all got funny faces, I'm sorry.
I'm not sure that's your vision, Lorraine.
Retinal screenings not to be recommended. Anyway, on the behalf of the council, I still want to place on record our thanks to all the staff for timeless efforts and for providing safe care to all our patients as the pandemic continues. I also wanted to add into this little point was that I just hope that staff morale is being considered as well as everything else within the psychological and physiological upkeep of our staff. There are issues, we all know there are issues within the trust that keep being brought up, and I hope that the morale of the staff isn't being impaired by this. There have been a number of governor meetings, government development session with NHS improvement, the membership database, GDPR, the FT and membership group are continuing the membership strategy. The Council of Governors approved the appointment of a new and non-executive director and the extension of Steve Ward's term of office by a period of 3 months. And the Council of Governors have received a copy of the draft quality account and is being consulted on the NHS improvement self-certification. All those meetings, I feel, on behalf of the Governors, really have been very, very useful. Looking ahead to July, a Governor-only informal meeting will take place on the 13th. Preparations for Governor's elections will commence in July. The Chair's appraisal will be undertaken on the 30th of June, it's tomorrow. And regular scheduled meetings with Director of Governors have been arranged to receive updates on the Recovery Support Programme, Urology and the Care Quality Commission. I don't think I've got anything else to add to that, Chair. Thank you.
Very comprehensive report. Thank you, Lorraine. Any questions to the head governor? No. Lorraine, thank you. We'll move on then from these items. I'm going to jump 57 and 58. Leanne will come back to item 57, but Wesley's come in and he's waited and he's come back in again. So Bridget, I'm going to come straight to item 59, the Freedom to Speak Up annual report. I'll pass the floor over to you.
Oh, thanks so much, Chair. So for the purposes of time, I'm going to hand over to Wesley to present to us some highlights. I'll take it as read in terms of the annual report, which is a requirement for board.
Thank you.
Thank you. So from the board report has been submitted. So from the 1st of April 2021 to the 31st of March 2022, 124 concerns were raised by the Freedom to Speak Up service. Within this figure, 41 were raised anonymously. Out of the 124, 41 included an element of patient safety quality concerns, and 88 concerns related to alleged unacceptable behaviours, of which 13 allegedly bullying and harassment. 5 individuals perceived feeling they had suffered a detriment in some form directly from speaking up. So we've explored this with colleagues who have raised the concerns. Some individuals feel they have missed promotion opportunities and some have left the trust. The North West Freedom Speak Up Guardian Group are going to be completing some work later on this year in September to continue discussion on detriment. So I can feed back after that. So with our slides, we're working with the relevant people and services, for example, Keith Bentham, Communications, National Guardian Office, to redefine and promote the Freedom to Speak Up service over this year. The Freedom to Speak Up service has been reviewed by the MIAA, the NHSEI, and we have had support from the National Guardian's Office, and together with, can you go back, please, Nicola? I'm still on slide 1. Together with the Cqc report, the niche reports, with their recommendations and outcomes, ways to improve the service. And following on from the NHS staff survey 21, we want to address the results of the survey because we want colleagues to feel safe, feel secure raising concerns, and we want to ensure that the trusts will address their concern. We need to raise the profile of the service and try to address these issues. We want to create the right culture and right environment within the NHS, and we should be open and honest when things go wrong. So we're going to be creating a new dashboard to triangulate the data. We're going to make contact with Respect at Work, Champion, Lee Jenkinson, the PALS, people in LD to identify hotspots within the trust where we can reach in and promote the service to encourage people to speak up. We want to ensure the feedback form is sent to colleagues who have raised a concern. Over the last year, we received 20 digital feedback forms, 8 were anonymous, 5 would raise concerns again, 2 colleagues provided feedback, not sure, and 3 said no. So we need to find out why. These reflected the staff survey, and some colleagues were not happy with the response from their managers to their concerns. Consequently, we're looking at creating a new feedback platform with i3, so colleagues who have left the trust are able to provide feedback without using the trust computer, because at the moment they have to use the trust computer to provide feedback to us. So recommendations from the MIAA, the NHSEI, with lessons learnt. We've got to do a weekly, contact the comms, and we've got to do like a lessons learnt statement with them within the bounds of confidentiality. We've got to be attending cultural, meetings such as the cultural programme and the minority group meetings to provide the service to ensure their colleagues are supported speaking up. We're going to increase the Freedom to Speak Up visibility, providing new Z cards and pens, and we're going to be doing walkabouts within the acute and community settings across the trust. And as a service, we're going to continually promote the BSF with all colleagues. Can I have the next slide, please, Nicola? So the improvements identified by the MIAA, we've got to emphasise the improvements we're making, that the lessons learned tab, where we can refer to cases where lessons learned have been shared within teams and more widely, and concerns from exit interviews are recorded and followed up. We're in the process of creating a shared platform for cases for Heather and I to use to access records from when I commenced this post. And we need to get consent from individuals that their cases can be shared between Heather and I. We've had like I said, we've had a meeting with Lee Jenkinson, Respect at Work lead, to discuss whether champions are able to signpost to our service, and that's been agreed. At the moment, there's e-learning modules, and we'd like to ask the board to complete the online learning. This is accessed through TMS and e-learning for healthcare, Health Education England. There's 3 modules: Speak Up, Listen Up and Follow Up. And it's for all clinical and non-clinical colleagues who work for UHMB, including agency workers, locums, bank staff, voluntary workers and students to complete. So it may be a photo opportunity if one of the execs, we could arrange for the comms to take a picture of one of the execs completing the e-modules if that's possible, and then we can put that on the comms to promote leading by example, so the execs have done the training, so we're encouraging all other colleagues within the trust to complete the training. There's 3 modules. All colleagues are supposed to complete module 1, line managers module 2, and senior managers level 3, but senior managers are supposed to complete all modules, and so are line managers module 1 and module 2. And we just want to ensure that everyone knows how to speak up and raise concerns, and that managers know how to receive them and resolve them. Obviously, we've tried to do planned walkabouts across the trust and see how that entails. Obviously, we'll have our Z cards and promotional pens to do that. Please, can I have the next slide, please? So this is how we're going to improve our Feed and Speak Up service. So we've met with Helen Turner, who was the Shrewsbury and Telford Feed and Speak Up Guardian. She was the exemplar guardian for the NGO. And we've identified that we're doing things very similar to what Helen's doing within her trust. So we're going to be doing weekly comms, promote the Feed and Speak Up service and visibility, and like I said, doing walkabouts. We've created a new app platform because Apple aren't supporting the Feed and Speak Up app from now. The people who have already downloaded the Feed and Speak Up app can continue to do so till the end of the year. But we've been in talks with i3 and we've developed a new platform, new app, and we've got to be piloting that now. And then once that's been piloted, then we've got to do a comms to promote that app. Obviously, it'll take some time for uptake from colleagues, but that's where we are with that. We're regularly attending the North West Feed and Speak Up network, meeting with other guardians. And please go to the next slide. And that's our Feed and Speak Up strategy. We're going to promote and empower all colleagues within the trust to raise concerns throughout our service. Thank you.
Thanks, Wesley. Thanks very much.
Any questions?
Yeah, I've got a few hands up. I'm going to go David, Jill, Bridget. No, David's put his hand down. Jill?
Sorry, I was just clapping Wesley.
All right, okay. Bridget.
Thank you. So thanks so much, Wesley. So it's really important that the Freedom to Speak Up service is autonomous and that Freedom to Speak Up Guardian presents, but I can imagine that's quite formidable. So thank you, Wesley. I think just in terms of the board, what Wesley's articulated really well is, so we've had a number of reviews, but also what is demonstrated is that we're broadly in line with many other organisations, but we need to continually improve. So within the RSP programme, under the culture and transformation piece, Freedom to Speak Up is there, and that's why we're able to gain some of this national support, because what I've asked for, Jill and I, as nominal leads around this, is that we want a work plan for the year to help the team and both the organisation in terms of Freedom to Speak Up is everybody's business, and that actually we can monitor the progress through committees quarterly, and then actually that will help inform our annual plan when we come to present next year. So there is a large piece of work around that, and what our aspiration is that how can we become outstanding in Freedom to Speak Up service? What does that look like, and how do we need to get there? So that's the work that's been underpinned really. So I'll look forward to hearing what happens next.
Okay, thank you. You want to come in, Aaron?
It's only a quick one, Bridget. So Freedom to Speak Up, just a thank you to Wes. It can be quite daunting coming to present to a board, so well done, you got that across really well, Wes, thank you. I appreciate Freedom to Speak Up is a theme that's been identified in some of the reports, but I think it was wider than that. It was about raising concerns, and one of the drivers that led to external parties raising the issue that raising concerns here might be something for us to consider was the amount of whistleblowing activity, the amount of issues that were presented outside the organisation rather than coming through the structures that we have. So I think what might be helpful for board at a future meeting is just a document that shows all of the available options for the organisation where concerns can be raised. And then for the board to take some view as to what level of assurance they want to take or what kind of information they might want to see in those platforms that we have available. So this is very specific because it's part of the requirements we have around Freedom to Speak Up and when it was launched about board visibility. But given the thematic issue, it might come up through the RSP programme or something similar as well. I'll leave that yourself, Bridget and Chris, to think about how to position that. But I just think given the feedback was wider than just Freedom to Speak Up, it might be helpful just to have a separate session or a separate item on raising concerns more generally.
Okay, thank you. I'll take that as a recommendation through the board. Anybody else put their hands up? You?
Yeah, very small. Well, it's not a small point, but thank you, Wesley. And I think also we should thank Heather because I mean, I think she's been making best use of trust resources recently. She's been tweeting about it, so it's nothing private. But so I'm sure she would be here to receive our thanks as well. And the only other point I wanted to make was Bruce, obviously retired, had been the senior independent director for several years, and obviously I think it's an annual report. We perhaps ought to just at the board just acknowledge the work he's done alongside Wesley and Heather, and possibly Sue as well. I assume prior to Bridget's arrival. Yeah.
Okay. And last question from me, Wesley. Do you feel that since you've been working with Freedom to Speak Up, that you and Heather, do you feel that staff are more confident now in approaching the Freedom to Speak Up officers?
I do, yes, but I think it's still a grey area because we know there's certain departments which aren't raising concerns, and that's where we need to deep dive into those areas, and that's why we've got the promotional stuff to go into those areas and to raise the profile of the Freedom to Speak Up service. So we are aware of some areas across the trust where we're getting limited concerns raised, but all in all, people who have raised concerns feel they have been listened to and their concerns have been addressed. But just going back to what comment before, following the niche recommendations, we have been doing some work with Richard and Katie Stretch from People in OD. So we were trying to align some pathways where people can raise their concerns up. So we've got like the grievance policy, Freedom to Speak Up, and I think trying to put people in what the outcome was is like where we try to direct people using one particular channel to raise concerns, but that's a discussion what we're having at the moment with Richard and Nicola and Katie, following the niche recommendations.
Thanks, Wesley. That's a really good point, actually, and does provide us some reassurance at least. Thank you. On behalf of the board, Wesley, if you pass back to Heather, our thanks for all the work that you do. I know it's a continuing thing. I know the execs will take on board some of the chief execs' comments, so we look forward to further reports and updates. Thank you.
No problem. Heather is on leave at the moment. She's had elective surgery, so I'll pass the comments across.
All right. But thank you, Wesley, for presenting this morning. Really
thank you. Bye.
Bye. Okay, colleagues, I'm conscious of time, so I'm going to whip us along now a bit. Item 57, urgent emergency care improvement. We're asked to review and support the Bay Partner Urgent Emergency Care Improvement Programme for the next year.
Thank you, Chair. So the report has a lot of detail in it, so I'm just going to summarise the key points. The 22-23 plan builds on the 2021-22 Urgent Emergency Care Plan, which the board approved this time last year. And that plan at the time included the investment in a stage project that's expanded our emergency department capacity, expanded our Exec, same-day emergency care facilities. It also saw the development of a priority assessment and discharge unit at Lancaster and has helped us refurbish some of our wards on Medical Unit 1 as well as the command centre. It also focused on the investment of 5.6 million in additional staffing. That was nearly 95 full-time equivalents for frailty pathways, which we just talked about. The Royal College of Emergency Medicine commitment to ED staffing levels within our emergency departments, as well as the expansion in our hospital home care team with all of the recruitment underway, which we've been talking about as part of the RSP updates earlier. Over winter as a system, we also sought to increase our surge bed capacity both in and out of hospital to safeguard our elective recovery at the time as much as possible and manage those winter pressures. So as a result of that plan at the time, the Trust obviously we didn't achieve the constitutional 4-hour standard. It is one of those perennial targets you'll see in our IPR we don't achieve, and this is obviously in response to how we're going to address that. And whilst we managed over what was a very pressured winter and more stable in terms of a position as we go into the coming winter, the Trust does continue to experience patient safety and quality issues resulting from high demand that's placed on our urgent emergency care services. And this may just by context is the highest attendances we've had, second only to July 2021, that we've had in probably about the last 7 years. So really high demand for our services coming through still. Also, in terms of our Cqc report, there are a number of must and should do's in that area as well. So to that end, the 22-23 plan builds on what we had in last year's plan and also addresses some of the additional risks that we've seen through not meeting criteria to reside in corridor care, specifically at Lancaster. In order to prioritise the plan, we have done an updated demand and capacity modelling, which you'll see in your pack. That has been conducted to include traditional bed modelling as well as ED cubicle hours modelling, which does reflect the actions needed to reduce the prevalence of care on the corridor, particularly at Lancaster. In summary, the data modelling in the pack demonstrates that overall the Trust is between 50 to 80 bed equivalents in deficit, summer and winter respectively. And the departmental cubicle capacity across the two sites is 19 cubicles short, 6 of those at Barrow and 13 cubicles short in terms of our ED capacity at Lancaster. So the plan for 22, 23 and beyond is designed to address those gaps through 8 priority schemes, which are included in the schematic in your in the report. 5 of those are the main focus throughout 22, 23, with the additional 3 schemes that are in an earlier stage of development and developed over a longer time frame, and they're the ones that are reflecting some of the national guidance that we've seen come through this year's planning requirements. So just to summarise, the key schemes include Exec, so continued expansion in our same-day emergency care services, the expansion in our frailty pathways and the continued work as part of our FIT team, the work around mental health and assessing our compliance with mental health standards and ED, as well as addressing the risk with our local authority partners around not meeting criteria to reside. We're also focusing on the work around decongesting our EDs, as particular evidence by some of the improvement metrics in the IPR he was referring to before around ambulance performance, but also includes now the virtual ward developments as part of the national planning guidance and the ICS requirement to introduce virtual wards. Also includes the urgent treatment centre co-location options and the improvements I mentioned before around paediatrics. The paper includes a clear timeline for those key projects over the next 24 months, with the longer term timescales to be developed. Obviously, they're more embryonic in their development and they will start to feature as we go through the next quarter. The schemes are being co-designed with our system partners with particular expertise. Just want to acknowledge the thanks we've had from Caroline and her team through NHS EI in helping us develop some of those plans, both locally within the team that we've got with us at the moment, but also connecting us with national experts in the area. In terms of oversight, the schemes will be overseen by the A&E Delivery Board through Bay Health and Care Partners and also through the SIB, with regular updates coming through the Trust Board via the IPR and also the specialty level IPR when they come into force in the next watch as well. And I'm going to stop there.
Very concise report. It builds up on our annual plan. Sensible. Any questions or comments?
Just one comment from me, Chair, and it's the reliance on partner contributions to the improvement. So Leanne highlighted that the A&E Delivery Board, where system partners sit around the table, is one area of scrutiny for performance against the improvement plan, which I chair. But the System Improvement Board, more recently, we gave this update at the last board, particularly where we're reliant on either local authority colleagues who are not meeting criteria to reside improvement, or wider system support for things like the urgent treatment centre co-location. I think when we bring updates to the board, as well as our own internal assurance for delivery, we need to draw out any issues and celebrate any successes with partners at this board, because whilst the A&E Delivery Board and the SIB do report, we don't have direct reporting lines into this board other than via the IPR. So we'll work on getting that wider assurance piece into the board at the same time, Chair. That sits with me and Leanne.
Great. Okay, seems clear enough.
You've got Jill's got.
Oh, sorry, Jill.
That's all right. I just wanted to say we reviewed this report at Quality Committee and we weren't convinced that all the schemes will be delivered at a pace needed to prevent some of going into Opal 4 again. And that was partly because of things like, as Aaron's just mentioned, not meeting criteria to reside and pressures across the system. But notwithstanding that, some fab work has been done on the different schemes within the trust. We did have a good discussion about it, but I just wanted to, having visited Dunmail Rise after the Quality Committee meeting, Dunmail unit, whether that you don't need to answer now, but whether Dunmail, which the staff there weren't aware of anything that was particularly going on in this area, but felt they could make a contribution. And I just wanted to make sure that the contribution from the Dunmail unit could be considered within this, because there looked like to be spare capacity there.
Thank you, Jill. Okay, colleagues. You're happy then to review and support the programme for the next 12 months? Well, 24 months, really. Yeah, taking into account, Jill, what you've said about our concerns around Opal 4 and the pressures on reside, etc. Okay, thank you. We'll move on then. Yeah, thank you. Item 58, the ICS, the Integrated Care System update, and the provider collaborative update. We've got the report in front of us. Anything to add on it, Chief Exec?
Only very briefly, because I did touch on some of the developments in these areas under my CEO's report, Chair. But the Chair and I are at a provider collaborative board communications event later on this afternoon. This is a signal, I think, of the newly constituted ICS's intentions around integration and how the system will work in the future, alongside the place-based development with provider collaborative board development and the community and primary care development pieces. The reason I say that is I I think the pace and scale of change and the permissions for improvement and getting to places that we might not have got to quite quickly enough before on things like clinical strategy and clinical service design, or some of the collaborative work we're trying to do in corporate functions. I think the new structures and the new way of working is going to get us to some of those decisions more quickly. So one of the actions I've agreed with the chair is to bring a revised mandate document, probably through some development work with the board about the areas in which those decisions are likely to feature. So the board's very clear on delegated authority or the connections we've got into the new structures that are developing. We do have an MOU, particularly for the provider collaborative board, but it's now probably 2 years old, and I think it's going to move into a different space. So just to make that point, Chair, you and I have agreed to bring that on. I'll take that action.
Thank you. This is a legal requirement from July, from Friday, when the ICS becomes the overriding responsible accountable body for the delivery of healthcare. So this will be an item that I'm sure will come back to the board as regular. Anything to ask the Chief Executive report at this point? No? Then we note the report. Thank you. We move then to item 60. We've all read it. We're asked to approve the trust quality account. Bridget, it's over to you, but I really don't want you to go through the whole account. And I would say to colleagues, if you've got anything around grammar or changes to format, that they speak to you after the meeting. Really, if you've got any issues about why it shouldn't be approved, this is your chance to raise it. Over to you, Bridget.
Oh, thank you. I will be really brief. The most important thing is it's not I'm presenting it, but it's the work of the contributors, and notably the company secretary on the call, but lots of other people. We are due to publish tomorrow, so given the chair's comments, would really appreciate those back. For assurance, it's been circulated to those that have been required, and we've had feedback. It is different to the requirements for publishing last year, and this year it's not required in our annual account, but we are required to have one. So I will take it as read, and any feedback is welcome, but we do need it back for publication for tomorrow, please. Thank you.
Okay, I think it's very well advanced. This we approve the publication subject to any comments to you by tomorrow, Bridget. Yeah, thank you.
Thank you, Chair.
Item 61, Health and Safety Executive Regulatory Action. The report is in front of us. It's now been closed because we've addressed all the issues. Company Secretary, anything to bring to our attention?
No, nothing further there, Mike.
Okay, we're asked to note the concerns and also the work undertaken and the closure of the notice and the HSE recoup cost for the visit, which was £2,000. All happy to note those. The issue has now been closed. Thank you. And then item 62, Company Secretary, please.
Probably a joint item between you and I, Chair, but I'll start things off. So Jeff has been with us for a year now, and at this point we would normally review whether or not we would extend his contract. I think Jeff may well find himself with a role within the ICS and therefore potentially a conflict of interest, and therefore the report alludes that he might step away at that time. There is now the opportunity to appoint a further special advisor, Dr. Karuna Nathia, got that right, who's the Director of Public Health for Lancashire, has agreed to accept an offer from the chair to join the board of director, and details of the doctor's background and relevant suitability for the role are set out in the report. Lastly, then, there is a piece of work which the chair is sponsoring with the Council of Governors and in particular the Nominations Committee around associate non-executive directors and non-executive director appointments. Mike has canvassed the non-executive directors regarding potential skills, competencies, backgrounds that we might look for in our next cohort of recruitment and selection, which is about to get underway. Is there anything that you want to add on that particular point, Mike, and the feedback you've had from NEDS?
I think the Council of Governors Nominations Committee will look at the feedback from the NEDs on the skills required. We're looking at 2 NED vacancies, 3 associate NEDs, which was approved by the Council of Governors next year. I think the only thing I'd point out as the chair is we would look very, very hard at BAME representation on the board in at least 2 of those posts with a good wind behind it. I'm speaking to Jeff tomorrow about the place-based partnership, boundary changes and issues. So I'll feed back to the board the outcome of any of those discussions. So I won't say anything more except that you know, Jeff is the special advisor to this board, and then I'll feed back the outcome of any discussions I have with him. SACD has agreed to come in. Fantastic for us because obviously it's public health. Otherwise, I have nothing else to add.
Very briefly, Chair, I'm pleased you mentioned, colleagues will be aware with the session we had with Yvonne Coghill last week. Chief Exec deeply uncomfortable at the lack of diversity around this table as I look around. That's on us. We have the permissions and the authority and the autonomy to recruit and make sure we have that diversity around this table. So I appreciate we've got that targeted focus, but we do need to make sure that we're putting a bit more purposeful effort, I think, in recruitment for that particular issue. I am pleased to see in the recent round of recruitments at the very senior leadership level, we've got a good and diverse range of colleagues, particularly in the clinical leadership and the Associate Director of Operations. And I'll be working with Hannah Chandersingh in a new role around some purposeful and focused internal succession planning and talent management around diversity, because despite our best efforts going out to the headhunters, we are just not getting diverse fields, and we need to take some positive action in that space, which we will do, Chair.
Yeah, 100% supported by the board, I think, looking down on that. Okay, so we're asked to extend the appointment.
Just one comment there, just for clarity, that the paper says that Jeff has been appointed to a leadership role within the new system.
Yeah, not confirmed.
So I mean, I think that just needs clarifying, because that then does make the recommendation, you know, are we extending his appointment or I mean, that's where I'm just a bit confused about this.
I asked the board to extend Jeff's period as an advisor to the board. I'm speaking to Jeff tomorrow about.
So this is
a role. So
this
it's just
this is at this point in time we extend him, and that might change at some point in the very near or distant future.
Yeah.
And the only other point I was going to make was, should we change that to support the proposal to recruit up to 3 associate non-exec rather than hold you to having to appoint 3?
Yeah. Yeah.
Just allows a little bit of flexibility.
And the Council of Governors nominations subcommittee will also have a say on that. But yeah, up to 3 non-execs and 2 NEDs. Yeah. Do you happy to accept the recommendations? Yeah. Great. Thank you. We'll move on then. Attendance monitoring register you've got in front of you. Schedule of business. No urgent business being brought to my attention. Okay. Colleagues, do we feel, I know it's been a long meeting, we're about 20 minutes adrift of the finishing time. Do you feel we've covered all the assurance processes and the issues that you wanted to cover in the board this morning? Yeah, thank you. Karen, your first board, welcome. I'll give you a few seconds. Any comments you wish to make?
No, just great to be here, great to really understand the questions that people are asking, the different perspectives, and I have made a lot of notes for me to go and follow up with questions after today, so look forward to that.
Look forward to talking to you. Okay then, at 12:51 I'll close the public board. Date and time is Wednesday the 27th of July for our next meeting, 10 AM in the boardroom. Colleagues, thank you. For those of you in the private board, should we start?